Good evening, everyone, and welcome to the 19th episode of a very successful E-Gurukul series of a surgical skill transfer and solving the clinical dilemmas by a stalwart in the field of gynecology by P C Mahapatra, sir. His dedicated passion for the sharing his experience and mentoring the young mind is very inspiring. Today also, sir is discussing a very important topic, that is the tackling the hemorrhage in the obstetric gynecology and the surgical options, tips and tricks following the clinical dilemmas. So without wasting much time, I will ask Dr. P C Mahapatra, sir, to host this session. Thank you very much.
Thank you, Sanjay. Can you hear me?
Yes, sir. Yes, sir.
Thank you, the whole team of Juventus. They're as vibrant as last year. They're more vibrant because Sanjay has joined, Kedar has joined, and Alad is always with there, and the support staff and all the people from the headquarters. Thank you very much for giving another opportunity and opportunity to meet my fellow delegates at least twice a month. In this juncture of post-corona or corona epidemics, for the last 1 year or so, we are continuously doing that. And that gives me pleasure that I have been able to talk to you, my fellow delegates across the country. And today, I again welcome to the episode 19. And again, the concept from the beginning, which we made it, surgical skill transfer and solving clinical dilemmas. And again, the greetings and blessings from the Lord Jagannath. And this episode I've targeted for tackling hemorrhage in obstetric gynecology. Tips and tricks, surgical options. Well, literally speaking, obstetricians and gynecologists are very familiar with hemorrhage. And particularly the obstetricians are absolutely day in and day out, they are submerged with blood. And who else in the medical discipline who can explain and manage the hemorrhage part, particularly in their own specialty? And this, we are different from other faculties in that. But in fact, when we come to the reality, the gynecological surgery, as well as the obstetric surgery also, there is a long way to go, because we have to go not only in tackling hemorrhage, but a preventive part is important for that. And therefore, I will share some of my views over the last few decades regarding how to approach the hemorrhage, the pelvic hemorrhage and obstetric hemorrhage for that. It's very difficult to cover whole topic, because if you take obstetric hemorrhage, particularly PPH, it will take at least a whole day to talk about PPH. But due to the paucity of time, you are all experts in managing for that. I will just give an insight and overall overview of this particular thing rather than go into the details, so that we can cover every aspect of the hemorrhage, particularly in the subject of obstetric gynecology. And in future episodes, we can again have a subgroup on a particular aspect and then continue it mainly on APH, PPH, or any gynecological elements for that. Now, therefore, I told that it's not the tackling hemorrhage. Once hemorrhage is occurred, there's not tackling, but how to have a preventive steps. So let us start from the preventive steps, how to look at it. The pre-op assessment of risk. There are some risk factors for hemorrhage. There are the patient profile is responsible. The physician's profile is also responsible. And the surgeon's profile is also responsible for the hemorrhage. So therefore, the pre-op assessment of the risk factor is important. Pre-op preparation of that is important. And then after that, if there is an intraoperative hemorrhage, intraoperative part during the time of surgery, how to tackle the hemorrhage in the various forms. And lastly, the post-op surveillance and management. That completes the whole part, starting from preventive to the therapeutic aspect. Now the preventive steps. Assessment and planning is important. I always emphasize also in earlier episodes also, in many sessions I've already told that we are surgeons. We are not simply craftsmen. With the decision and dissection, more important. In last episode, I've discussed with that also. So the assessment and planning is important. That not only makes our surgery much quality better, but our mental conditions, the preparation should be there. that beforehand we must plan it. If we expect that this problem could occur, the chances of hemorrhage is expected in this particular case, what precautions I will take, what measures I will take. A mental preparation should be there for that. So this is assessment and planning is important. Second important, in the era of high-tech surgery, the gadget-oriented surgery, you must be able to understand your own team as well as tool. The earlier, the conventional surgery, the team, understanding the team of anesthetist, the assistant is important. But here the tool, understanding the tool is also important for that. And more so, particularly in tackling hemorrhage, these are very, very essential part. You must understand your own tool and your assistants much more better in there so that you can tackle it better way. Understanding the surgical anatomy is absolutely important for surgeons. But again, I will supplement altered anatomy. You must be familiar with the altered anatomy for that, because of previous surgery, previous diseases, there is alteration of the anatomy. So that understanding should be there. Understanding the avascular pelvic space and planes. God has given us very, very important thing to the pelvis. So the creation of the anatomy, pelvic anatomy has been designed by God in such a manner that there are vascular spaces, there are avascular spaces. There are planes where you enter and fly absolutely safely. And therefore, particularly in pelvis, we have again known that there are very distinct avascular space, like a paravesical space, pararectal space, presacral space. All these has to be clearly understood by them. And therefore, the planes of dissection particularly is to be noted for that. If you go through that, the preventive part will be there. And if you do not follow that part, you enter into a wrong planes and a wrong space, you create more a problem in bleeding and hemorrhage for that. This is important. And people say that the surgeon is doing a bloodless surgery. It's not the question of bloodless. He is able to go through that particular plane, and therefore the bloodless surgery is there. The same surgeon, if you go enter in a little anterior or posterior, it will be a messy surgery for that. Gentle tissue handling. That's the basic philosophy of surgery, that tissue handling, gentle tissue handling is important all throughout the surgery. Otherwise, that will be a miss. Understanding the pathology. As far as hemorrhage is concerned, the hemorrhage differs according to the patient profile, according to the pathology, according to the disease profile, malignancy, infection, adhesion, these are all important. So this alters the tissue characteristics, the tissue dissectability, the tissue, I think, characteristics as far as the vascularity is concerned. And therefore, even if you go through the real plane and you are a very good surgeon, that is expected. And therefore, the planning is, I told that the planning is important for that. And last but not the least, you stick to your surgical skill and philosophy. Try to upgrade the surgical skill. And you can learn from your own mistake, or while doing a more of surgery, you can go to the autopilot mode and automatically have a clear surgery with least hemorrhage for that. Now, pre-op assessment. In the pre-op assessment, the procedure is important. What procedure you want to do it, whether it's an elective procedure or emergency procedures. Whether there is a risk factor for coagulative disorders. As far as hemorrhage is concerned, this is a primary importance. Risk factor for coagulative disorders. You must find out from the history as well as examination whether this is at risk for coagulative disorders, so that you treat it before going for a surgery, particularly in a case of elective surgery. Assessment of anemia and pre-op correction. This is very important, a common situations in our practice. Anemia before surgery, if a patient you are planning for a hysterectomy or any elective procedure, anemia. If there is an anemia, even the bleeding may be less, but the life, affection of the life is much more. And therefore, if the hemoglobin status is normal, the patient is able to withstand the blood loss. That's important. And therefore, the assessment of anemia preoperative is very important. And not only assessment of anemia, the pre-op correction. In our practice particularly, say commonly, if you're doing a hysterectomy for a menorrhagic cycle, for a fibroid, patient is bleeding, hemoglobin has dropped to 8 gram, 7 gram, 8 gram, 7 gram. There are, I have seen earlier, people used to correct it by giving a multiple units of blood transfusion and then operate immediately. I think there is a change in the strategy for that. There are agents which you can use it to stop the bleeding. There are agents which can be used other than blood to raise the hemoglobin status, like iron therapy. So this is all important. Correction, whatever it may be, assessment of anemia before surgical correction as a before surgery is important. And that will reduce the hemorrhage, not only reduce the hemorrhage, but the capacity of the healing power of the body also. By giving a substitution of the blood and doing an elective procedure, the healing power will not be there. Therefore, I will always prefer these elective cases should be deferred after correction for that. Assistance of other disciplines. You take help. If there is a coagulation disorders, you take help of transfusion specialist, pathologist, a hematologist for that, and therefore, accordingly, you can go for that. If the other disciplines, say for example, you have taken ecosprin, you have taken the clopidogrel, which is really affecting the PTA, PTT. These are the cases you take help of the concerned people and stop it before their surgery for a few days before that. Otherwise, the bleeding will be more. And in cases where there is a difficult cases where you find that the pathology is completely different, as I've already told, there is no ego. You can take help of other disciplines like a surgeon friend, a urologist friend, a gastroenterologist friend. If there is a need of the surgery for that also, it will really improve the quality of this surgery. And if necessary, you can take help of another colleague of yours and take help. There is no ego for that. Counseling and risk assessment. This is important. You have to counsel the patient regarding the risk of that particular individual. And of course, in all surgeries, the checklist and documentation, which we are very poor in checklist, providing the checklist. I think as per the checklist and documentation prior to the surgery, this is important as a part of the pre-op assessment. Now, these are some of the risk factors for coagulative disorders. History of spontaneous bruising or bleeding, history of unusual bruising or excessive bleeding after surgery, family history of bruising or bleeding after surgery, medication associated with bruising or bleeding. As I have already told, the ecosprin, this is all the aspirin as well as clopidogrel. There are some medications which is affecting the PTA, PTT. You must treat it. Current medication associated with the bleeding, alteration within the past week, previous coagulation testing, current coagulation testing, all has to be prepared as a part of the pre-op investigations. Now, the procedure, which we say is either an elective or emergency, either for benign or malignant, conservative versus radical, conventional versus surgery versus minimal invasive surgery like laparoscopy and hysteroscopy, single versus combined surgery. So these procedures should be understood before, so that each cases, the expectations of bleeding and the manner in which you tackle the bleeding will differ from one case to the other. Assessment of anemia and pre-op correction, as I was telling. You have to find out the cause of anemia, the degree of anemia by hemoglobin estimation, morphologic type by peripheral smear, and cause of anemia. And majority of the cases are iron deficiency anemia in our practice, and there is a very effective way of combating this particular thing and substituting with the iron rather than the blood. Then arrest of bleeding by medication, as I've already told, if your patient is bleeding, you can arrest it by medication, give a hormones, give a progesterone to stop the bleeding for that. And role of iron therapy is immense, particularly in a pre-op preparation. And therefore, the role of iron therapy, particularly I'm a strong protagonist of the parenteral iron, the ferric carboxymaltose, which is very, very important as not only as an efficacious molecule, but really with the least side effect, we can use it. And within 4 weeks, it can be really normalized, and then you can do the surgery for that. Place of blood transfusion. I always say 1 unit of blood can easily kill a patient, but 1 unit of blood rarely saves a patient. But if the patient requires blood, she will require more than 1 unit of blood. I don't deny that there is no place for blood transfusion. There is definitely a place for blood transfusion. And when hemorrhage is an entity, in cases where there is a blood loss, it has to be replaced. There is no place for iron. Replacing iron therapy cannot be compared with the blood transfusion. But at the same time, because of the risk of blood transfusion, just giving 1 unit of blood will not serve the purpose for that. And particularly if the patient is anemic, severe anemia before surgery, you correct it by giving a blood transfusion and then raise it by the iron therapy for that. But don't raise it by multiple blood transfusion for that. But in a case where there is a malignancy, we cannot wait. The time is important. In the emergencies, if there is a bleeding continuing, so in that particular case, there is definitely a place of blood transfusion, which we will just tell. If there is a particularly hemorrhage, a very life-threatening bleeding is there, say for example, in surgery, you have already, there is a damage to the aorta or inferior vena cava or pelvic veins. These are the cases a massive blood transfusion can be required for that immediately. So this has to be done. So this assessment, pre-op, intraoperative, and post-op blood transfusion, periods of blood transfusion is very, very important. Pre-op, I have told that for just stabilizing it, for correction, you don't do it. But intra-op and post-op, there is a need in emergency when there is a loss, has to be really balanced with that. Now, component therapy is there. Now, whole blood, when in the past, when we were students, we were only doing a whole blood therapy. Now, the therapy has been changed to component therapy of the blood, which is now every blood bank has a component facilities available, and you can have the component therapy of the packed cell, component therapy of the platelet, component therapy of fibrinogen level. So all these can be done with that. Now, a little bit about the massive transfusion protocol. I think this is important. When there is an acute blood loss to a considerable extent for the saving life in emergency, there is a place for a massive transfusion protocol for that also. Now, a little bit about place of autologous blood transfusion. I have told when I dealt with the ectopic, where there is an auto transfusion, we have past experience of few cases of auto transfusion in which we collect it and then infuse at the same time during the intraoperative period for that also. And I remember, again, autologous blood transfusion pre-op. Is there a place for pre-op autologous blood transfusion? I remember when I was doing a post-graduation, the greatest enemy of the surgeon is the anesthetist, and particularly in the government hospitals. And therefore, for a petty matters, they advise keep 2 units of blood ready, and then only I will give a fitness for anesthesia. If everything is normal also. Hemoglobin is normal, there is no problem, we don't need it on that, but still blood is required. They want a blood, otherwise they will make it unfit. So I told my professor, sir, we will do one thing. We admit the patient, say for example, we are planning for surgery after 15 days, particularly for a patient. We will remove we'll take 2 units of blood or 1 unit of blood from that patient and store it in the Red Cross blood bank. And during the time of surgery, you bring it. And during the time, I think 1 week or 2 weeks, her blood hemoglobin will be raised also. So this is definitely a place for that. This is known as autologous blood transfusion. There is a place for that, but there are some criteria which are the patients they can have an autologous blood. So autologous blood transfusion, pre-op and intra-op auto transfusion, this has a place particularly in the current situation for preventing or managing the tackling the hemorrhage. So place of blood transfer in gynec surgery, pre-op, correction of anemia, I have told, standby during surgery and donor. This is important. So pre-op, there are various types of patients. So one group of patients where there is a severe anemia or the emergency surgery is necessary or malignancy, you have to correct the anemia by blood transfusion. There is no doubt about it. There are some cases where we require a standby during surgery. If everything is normal, patient is anemic, say for example, 8 gram, 8.8, 9 gram hemoglobin is there, and you are planning for a cesarean section. So there you make a standby during surgery or a donor kept ready so that in conditions of emergency, you can use it, not arrangement of the blood and transfuse it right from that. So therefore, there is a pre-op. These are the 3 main values in the pre-op. Intraoperative. Intraoperative depends on the particular case as far as the quantity of unit is concerned, the type of transfusion of component therapy of the whole blood, and the timing when you use it. I think the anesthetist can guide you during the time of surgery. If there is a blood loss, that is important, that this substitution of the blood loss should be there for that. And autologous, I have already told pre-op, I have convinced that intra-op auto transfusion, and therefore in intra-op also, nowadays the concept of cell saver has come out. We recirculate, even if there is an amount of blood loss there during time of surgery, the recirculation of that blood into the cell saver machine, where we can do this cell component, we can find out and store it, and then if necessary we can transfuse it to the same patient for that. So there is a place for cell saver for nowadays. Mass shift transfusion protocol is another aspect. In a torrential bleeding, in life-threatening situations, the massive transfusion protocol is necessary. And in post-op, you have to find out whether the need for the transfusion. If there is a need for transfusion, then it should be given. Otherwise, we can find out alternative methods of giving an injectable iron, so that the quantity, the need, the type, and again the timing is important in the post-op, depending on that particular patient, what is the sequence of events. Criteria for elective pre-op autologous transfusion, blood donation. This is important, which I was just telling it. Hemoglobin, this reminds me about 20 years back when I was a postgraduate, 40 years back when I was a postgraduate. Hemoglobin of more than 11 gram per cent, or a Paxil volume of less than 34%. Phlebotomy no more frequently than every third and not within 72 hours of surgery. Less than 18 years of age. No active infection, no angina, no myocardial infarction, no congestive heart failure, no aortic stenosis, no hypertension. These are all criteria, but the majority can have autologous transfusion for that period. So massive transfusion protocol. Let us discuss, but very rarely massive transfusion protocol is necessary. In my experience, I have yet to find out, God forbid, I am not able to see that. And in occasions, I don't want also a massive transfusion protocol, I pray God. But it could be possible. Class 4 shock and estimated requirements of at least 10 units of blood. Both substantial acute or imminent blood loss and likelihood that substantial blood loss will continue over short time, and estimated requirements of at least 10 units of blood. Initial product release, continuation of massive transfusion protocol, and cessation of protocol. Initial product release, if massive transfusion protocol is activated, an immediate type and screen should be sent to the blood bank. Cycle 1 will be completed by blood bank personnel within 30 minutes of activation for transfer to patient care. It should be a continuous process of these 3 phases. Cycle 1 includes the following: 10 units packed cell blood cells, 6 units fresh frozen plasma, 1 unit of platelet. Continuation, the blood bank by default will continue to prepare cycles at least every 30 minutes until the protocol is discontinued. Cycle 2 and all subsequent cycles include 6 units packed red blood cells, 6 units fresh frozen plasma, and 1 unit of platelet. Cessation of massive transfusion protocol. Decision to stop the MTP can be made by the attending anesthesiologist. Patient indicators for cessation of MTP include extirpation, hemodynamic stability, attending anesthesiologist discretion for that. And therefore, fortunately for gynecological purview, we rarely find the chances for massive transfusion protocol as compared to the other faculties for that. But it should be kept in mind. Maybe that you may be needed for that. But intraoperative hemorrhage and substitution of blood loss, that's important for that. It is said that 15% of the blood volume, if it is lost during surgery, I think there is an indication of transfusion for that. The anesthetist will tell that there is an indication for transfusion for that. So tackling intraoperative hemorrhage. Now, what are the technique which is there, tips and tricks for tackling intraoperative hemorrhage? Well, decades before, William S. Halstead, chief surgeon in Johns Hopkins Hospital, way back in early 1900, he gave a theory: surgical technique, meticulous dissection, gentle tissue handling, accuracy in hemostasis, precision in wound approximation, and asepsis. These are all important. So it is indirectly related to the hemorrhage, intraoperative hemorrhage. If you do not do a meticulous dissection, if you are rough in tissue handling, accuracy in hemostasis should not be there, and wound approximation precision is not there, and moreover, the infection is there. Second important aspect is knowledge of basic surgical anatomy. Third is exposure, appropriate instruments, and technique of suture placement. The exposure important, the light is important. If you're going for a different intraoperative procedures, have a different views for that. Conventional procedures, a good light source is important, good retractors are important, good assistants are required. In an endoscopic procedure, good camera vision is important, and good assistants are important, good hand instruments are important. So these are important. You must understand the team as well as tool for a better knowledge for that. So intraop techniques, what are the different techniques in opportunities? Where is the level of how to tackle hemorrhage? Number 1, prevention. I have told that yes, you go through the correct planes and the pelvic spaces, avascular planes and avascular places, and a good tissue handling and dissection, then the prevention will be there, the bleeding will be less. If at all there is a bleeding, there is a different ways to tackle, and you have to find out which is the type of bleeding, what is the type of bleeding, and how to tackle the hemorrhage. Whether the hemorrhage is a small bleeders or a large bleeders. If there is a small bleeders, it is easy to tackle with the electrosurgical device also. If there is a larger bleeders, it's important. Larger bleeders, you catch the bleeder individually and then either ligate it or do a vessel sealer for that. Whether isolated versus generalized. If there is a bleeding from the uterine artery, spotting, you can catch it. But the generalized bleeding in the peritoneum with rectosigmoid is a difficult thing. Whether it's arterial versus venous, it's important. Arterial blood versus venous blood. Arterial blood is easy to control, but venous bleeding is very difficult to control. And really surgically tackling the venous bleed is really much more challenging than arterial bleed. And how to control, whether by suture or by clip or by electrosurgical device, that depends on the type of bleeding and on the type of location, which artery or which vessels or which vein there is there. And it differs from conventional versus minimal invasive surgery. Conventional, you have to be very apt with your conventional instruments like the hemostat forceps, like your assistant, and catch hold of that, either suture it or apply the bipolar. Whereas minimal invasive surgery, you mainly depend the arrest of bleeding by mainly the electrosurgical device and other power device. That's important. You cannot handle that. Without that, you cannot go for minimal invasive surgery for that. Now, there are prevention hemostatic agents. Apart from it, the local hemostatic agents or the systemic hemostatic agents. Local hemostatic agents I've discussed with the little part of hydrodissection. I'm not going for the hydrodissection, but the local installation of the dilute adrenaline or the vasopressin solution, we are all familiar with the hemostatic agents, and that is helpful in many of the surgeries and preventing the hemorrhage for that. Systemic, the tranexamic acid, which has been used invariably by all gynecologists for that also. Little bit about tranexamic acid, I will tell the real indication which accepted is two indications. One is a menorrhagia, another is a thrombophilia. These are all standardized indication of tranexamic acid. But there are many off-label use. And off-label use, we can use it in all types of surgery, preoperative or intraoperative. Tranexamic acid, we can use it because it's a very good effective drug, as because related to the plasmin receptors and the fibrin plug, and that proved to be very effective, and that can be used in other general indications of pre-op as well as the intra-op. Many people use the tranexamic before cesarean section or before any surgery for that also. Or there are many people who, depending on the surgery, when they find the generalized oozing, they use the tranexamic acid intraoperative. So intraoperative, apart from the hemostatic agents, the tourniquet. The brightest example of tourniquet is before a myomectomy. When we're doing an abdominal myomectomy, you apply the tourniquet, obliterate the uterine. I will show in my video how the tourniquet is being applied for that. Then recognition of avascular space and plane. That's important. Recognition of avascular space and plane. And if you compare the conventional surgery with the minimal invasive surgery and laparoscopic surgery, when there is an hemoperitoneum, the space and plane are better realized. And once the hemoperitoneum is there, once you are gone through the space, the initial entry into the space, the hemoperitoneum will facilitate for the space and create a space more so that it is better, which is not been located as you compare to the conventional surgery for that. Of course, the paramount importance is your skill, surgical skill. So steps for management of hemorrhage. Initial assessment and management is important. And initial management is there, but if there is a persistent bleeding, then what should you do? Persistent bleeding. You should find out why there is a persistent bleeding immediately after. You take help of other people and recourse to the other alternative methods for that. That's one. And commonly in pelvic surgery or in any surgery also, in gynecology, I particularly say that the principle of 3 Ps, pack, press, and pray. It doesn't, I think it acts miraculously, particularly in a case of generalized bleeding You cannot catch a single isolated artery or vessels. If there is a specific artery and vessels, you just catch it and suture it. There is no problem. But if there is a generalized bleeding or a bleeding coming from the veins, particularly generalized oozing from the veins, the pack press is very, very important. But you have to take a patience out of it. So packing patience. So press the area with the mop. You press it for a particular time. You don't just press it for 30 seconds and then removing it for that. So press it at least for 2 minutes, 2 to 5 minutes. You press it, and believe me, the generalized bleeding and moderate, mild to moderate venous oozing can be easily really blocked, and easily you can have a bloodless field after that. So this is important. The press is important. We do a packing for a different entity. Packing, you give a uterine packing, you give a packing particularly for the vagina after vaginal hysterectomy and all that to prevent a reactionary bleeding. But I think I'm not convinced about this particular pack which is there to accepting the balloon Bakri and a uterine tamponade. The pack, conventional pack, is not going to help in a case of PPH or in a case of the preventive part in a case of vaginal hysterectomy. Earlier we are giving it, but I feel that the primary is very important. The primary hemorrhage, the location is very important than the pack for that. But this is only a part which helps it, but it's not basically it differs from person to person for that. The tissue sealants and hemostatic agents. This is important. I have told about the systemic tranexamic acid, but there are local tissue sealants and hemostatic agents. Many people have used it, starting from the mechanical to the gauze to the these various agents like the Sargicel, or various marketing people have devised many of the local tissue sealants, and they can help in arresting the bleeding, particularly for generalized bleeding, particularly in a case of minimal invasive surgery or a laparoscopic surgery. But it is really there are some, it gives a little effect, but psychological effect to the surgeons also for that. But there is definitely some use of it, and we are using in a minimal invasive surgery of the different Sargicel or different the preparations for that, hemostatic agents. Place of arterial embolization, where the facilities exist, now they can do a place of arterial embolization, particularly to block the particular vessels, particularly the uterine artery embolization can be a very good option if there is a need during the intraoperative or even pre-op also. In a case where there is expected bleeding is much more, you do a pre-op uterine embolization and then start the surgery. I think you can save in that period. There is a place for uterine arterial embolization, which the interventional radiologist can do the procedure for that. Then, of course, it's our domain as vascular ligation procedures by the gynecologist. One must be familiar with the vascular ligation procedures, the hypogastric, the internal ligation, the ovarian vessels, the uterine artery ligation. It's not a very difficult job for that, but the need has to be found out and the efficacy should be found out for that also. There are various indications for that, but routinely don't think that if you apply that, all PPH, you apply that. And there I have seen the stepwise devascularization procedure, bilateral internal ligation procedure, and by the time you decide for hysterectomy, patient is gone. And therefore, right decision for that particular, because the patient's life is important for that, but this could be an additional, definitely helpful procedures for many indications for that. Now, what are the high-risk areas? You must find out. As I have told that there are some safe and very good pelvic avascular space and planes. Similarly, there are some high-risk spaces, high-risk areas where you should be careful that these are vascular areas. Be cautious about it. Iliac vessels, obturator fossa, pararectal space, retropubic space, aorta and vena cava, particularly in the dissection, nodal dissection, and presacral space, particularly presacral space. So these are the cases where the veins are much more for that. These are high-risk areas for that. And lastly, whether there is a place for drain in management of hemorrhage. The drain is an optional thing. Again, Halstead told. What is the indication of drain? When in doubt, drain. I think that's a very broader sequence. When in doubt, drain. You don't have a doubt and don't drain it. And whenever there is a place, a generalized oozing, and seeing the generalized oozing continuing, you don't do, the drain will have a solution for that. It will have a compression attitude. But there is definitely an indication of drain. After you do a good hemostatic surgery, after you do required tackle the hemorrhage, then it can be an additional thing to say that whether the further drain is there or not, bleeding is there or not, and you put a drain. Otherwise, putting a drain and then recognizing the drain and post-operative again explore it, that doesn't have any meaning for that. These are tissue sealants. These tissue sealants, there are physical agents like bone wax. Dry matrix are topical observable like Instat, Surgicel, Snow, Arista. There are a lot of pharmacological preparations starting from the portion gelatin to the polysaccharides to the microfibrillar collagen, and biologically active agents like a thrombin, Embithrum, Ricotrom, Flowshil, Surgiflow, fibrin sealants like Tisel. All are there and market is there. You must be using that, starting from the dry matrix to the synthetic sealants like Co-Seal and BioGlue. Some glue are there. So these are all tissue sealants and hemostatic agents which can be a supplement to your primary arrest of bleeding by a surgical maneuver. Now, post-operative. Post-operative needs a surveillance and monitoring. If there are some cases, there are two types of cases when we find that there are some at-risk cases, there are some unexpected cases. At-risk cases, you must have a thorough surveillance and monitoring. But all cases also do have, some cases do manifest unexpectedly. So monitoring post-operative, particularly for hemorrhage, is important, and more so when at-risk cases, they should be monitored much more better than the general cases. Then the degree of hemorrhage, the assessment should be there by clinical methods, by biochemical methods, and biophysical methods. This is important. The degree of assessment should be there by clinical methods, by the parameters of the different vital parameters you can know, including the hemoglobin status, and if take help of the sonography, and if there is a bleeding, internal bleeding, you can diagnose. If there is a mass, you can diagnose. So biophysical post-operative, these are all degree of hemorrhage post-operative. You can take help of that and diagnose that there is a hemorrhage for that. Conservative versus surgical intervention. Then only you can say that whether the need for a post-operative exploration or surgical intervention, or that can go for a conservative. Suppose you find that you have done a hysterectomy, there is a small hematoma in the vault, and sonography can demonstrate that there is a small hematoma, basic parameters, the vitals are stable, you can have a conservative management for that. But if there is a bleeding going on, intraoperative bleed is there by ultrasound, you immediately go for a surgical intervention for that. And systemic hemostatic agents, blood transfusion, there is a place post-operatively also. As I have already told, that if there is a bleeding continuing and there is a sufficient amount of blood which is going to affect the system, I think there is a place for not only 1 unit, but more than 1 unit of blood transfusion, along with the hemostatic agents and the systemic use of tranexamic acid. Now, every surgery is easy. Every surgery is difficult. It is the surgeon who makes the surgery easy or difficult. I think that individual opinion, individual decision is important. The skill is important for that. And remember, I'm giving the OT mantra to all of you. All must be realized, and this is my conviction, that adopt two things. Hemostasis for any surgery, hemostasis for the surgeon, oxygen support for the anesthetist. If these two are carried out, I believe that you don't get an intraoperative fatality or table death. Table death can be managed very well if you target these two. Gynecologists and surgeons should prioritize for hemostasis. Majority of the cases create problem, and intraoperative will give rise to a postoperative problem also if you are not tackling it during the time of surgery. So again, remember, hemostasis for the surgeon, oxygen support for the anesthetist. If these two are carried out, no OT, no table death or intraoperative morbidity. Now, I've told an overview of the hemorrhage in obstetrics and gynecology. Let us find out hemorrhage in obstetric practice first. Obstetrics is a bloody business. And when it culminates in bleeding, it's a bloody business. Remember that. And what are the key issues? Key issues when we go from the beginning of pregnancy till the end. The key issues, there is no, we don't discuss about the details of each event, but highlighting some of the important events, key issues: bleeding in early pregnancy, bleeding in later pregnancy and labor, and postpartum. These are the three main areas where you want to tackle obstetric hemorrhage. Bleeding in early pregnancy, the incidents are abortion, molar pregnancy, ectopic pregnancy. People think that abortion is a very minor thing for that, but I've seen deaths following up incomplete abortion. If appropriate intervention is not done, even with a evacuation in the periphery, the bleeding can be stopped. But patient have died by transfer from the periphery to the referral hospital. On the way, patient has died. It's simple. I think it's a prevention which can be done. So bleeding, don't ignore that. So bleeding in early pregnancy, abortion, very important. When there is an active bleeding, there are many cases where there is a bleeding continuing, and don't wait for that and you evacuate. Molar pregnancy, ectopic pregnancy, the concealed bleeding will be more, and diagnostic armamentarium nowadays by sonography, it is very, and Vita it is very easy to diagnose to the accuracy of about 100% ectopic pregnancy. Bleeding in later pregnancy and labor, we divide APH, antepartum hemorrhage. We call it as APH. I don't know, just to revive, everybody knows, are familiar with the APH. Either it could be a placental abruption or it could be a placenta previa. Both are involved in that APH. So the tackling of APH, particularly the surgical management of APH during cesarean section, the placenta previa, starting from the difficulties which you find about the bleeding till cesarean hysterectomy, all of you are familiar about it. I need not emphasize that, but give a brief history, brief thing about the APH, which we can discuss in next episode, subsequent episode. Again, rupture uterus is another thing. With the bleeding is there, and how to tackle the bleeding in a case of rupture uterus. These are all features of hypovolemic shock because of the bleeding. Then very important, postpartum hemorrhage, PPH. Another time we are lucky now that it was the first cause, most important cause of maternal mortality. Now, I think by the innovative molecule like the prostaglandins molecule, by the institutional delivery, increasing number of institutional delivery, and of course, the skill of ours and awareness of the PPH drill and monitoring and the immediate effect, we could be able to reduce this PPH deaths as a maternal mortality. It has come down a little, but still it is not abolished. But still there is a place where the people are dying because of PPH, even if you attempted wrong. I think these are the cases we have a long way to go. And one could understand some of the cases where the stepwise management of this PPH is important for that. Again, it will take a long time, but I'll give a brief overview of that. Now, tackling early pregnancy bleeding, the diagnostic accuracy by the gadgets is important. Appropriate surgical intervention in right time, as I've already told, simple evacuation, LAP intervention particularly is important. And in a mid-pregnancy, say for example, in second trimester, early second trimester, the hysterotomy. Many cases we have to do a hysterotomy also, not for MTB, medical termination pregnancy, but in a case, suppose say for example, a lower segment, low-lying placenta in a 16-week size uterus, low-lying placenta covering the os, you have to do it hysterotomy. Or if there's a morbid adhesion, even in a 16, 18 weeks pregnancy, there is hysterectomy had to be done, first life-saving for that. And therefore, I have many occasions to find out for that and share with you in my video for that. Now, surgical management of APH, you know matter, but the brief review overview I will tell, it depends on the duration of gestation, it depends on the fetal status, it depends on the maternal status, degree of placenta previa, minor or major, whether it's a morbid adhesion, which is very important. And nowadays, by ultrasound, we can diagnose there's a need. If there's a low-lying placenta, ask your sonographer, or if yourself are doing it, always if there is a low-lying placenta, exclude morbid adhesion by putting a Doppler for that. Then the timing of intervention is important. In APH, we know that placenta previa, the timing of intervention. When we were students, we were having a chronic care. When the patient, we know that repetitive bleeding occurs, and therefore we have a chronic care because we have to prolong the fetal survival and continue it up to about 37 weeks, fetal maturity, 37 weeks. But nowadays, in a low-lying placenta, when the fetal survival is absolutely up to optimum by 34, 35 weeks also, in a major degree of placenta previa, I think we cannot wait for that, because in torrential bleeding can occur in one case where in the dead of night, you cannot manage and the patient will die of hemorrhage. So therefore, things have changed, and timing of intervention also. If there is a heavy episode, you do it even earlier. But if there is episodes and episodes after that, at least our aim is to continue in case of major placenta previa, minimum up to 34 weeks and interfere. You can give a glucocorticoids and interfere. Don't go for 37 weeks also, particularly in the case of major degree of placenta previa. And intra tips and tricks is important in placenta previa, and the anterior placenta previa is really difficult than the posterior placenta because there is a lot of engorged veins. The bleeding will be more. You can tie the vessels above and below and cut it in between. That's a very important way. And entry into the placenta previa, the placenta, you can go through the placenta and catch the fetus and then deliver it, or you can shear it and on the side and separate the placenta and deliver the baby as quickly as possible, and then give an ecbolics to control the bleeding. If there is a placenta posterior placenta previa, after the delivery of the placenta, non-morbid adhesion, after the delivery of the placenta, there are invariably bleeding from the bed. So bleeding from the bed, you can have a suturing of the bed, and hemostatic sutures, you can apply it under vision, so that there is a very good thing that you can control that. So this is important, the intraoperative tips and tricks. You can combine it with the bilateral uterine ligation for that. You can do, if necessity, you can do a bilateral interiliac ligation along with that procedure. But usually it is not necessary with the minimum techniques of the surgical techniques. In non-morbid adhesion, you can do it. But in morbid adhesions, I think it is very difficult. And majority of the cases, if it is a multiparous, I think I will advise it for seizure and hysterectomy in that particular case, in the morbid adhesions for that. Otherwise, this can be managed. So these are the tips and tricks in the APH management during the time of cesarean section, which I have already told during the episode of cesarean section also. Just recapitulating again, I'm emphasizing this. And of course, the post-op surveillance. In a case where it is already at risk, because it is already done and managed during intraoperative period, you follow up and monitor during the post-operative period, and supplementation of blood, then the general monitoring of the patient, and this is important as a surveillance and monitoring protocol. Now, postpartum hemorrhage, what are the surgical? That is medical management, surgical management. Medical management, I will not highlight on that, but the postpartum hemorrhage, the surgical management. The main thing we divide into the PPH, whether it is an atonic PPH or a traumatic PPH, whether there is an inversion of uterus is there or not, whether it is a primary PPH or a secondary PPH, and accordingly the treatment will vary. Atonic PPH, place of surgical intervention in atonic PPH, mainly the atonic PPH will require a medical management for that, but place for the place of surgical intervention like atonic PPH, particularly for stepwise devascularization and the compression suture. And of course, along with that, the packing, the uterine pack, the uterine tamponade, that can help, and uterine suction. I will show the different methods of uterine atonic PPH. The timing of infection and types of inversion. Surgical techniques. Therefore, packing or uterine tamponades is one important aspect, but the conventional packing in our earlier days were packing the uterus in PPH with the gauge, roller gauge. The roller gauge is not able, the tight packing is important and all that. It's not physiological also. Therefore, the roller ball is not accepted and the efficacy is not much. Therefore, we are using for the other balloon tamponade for that. Balloon tamponade could be an option for the management of PPH as a surgical technique. The suction, the insta-stop, and very of our innovative gynecologists like Panikkar and other people have devised that, and you make a suction, and this also acts very good in the surgical techniques of preventing the PPH. Achieving hemostasis during LSS is very important, as I have already told, that from the beginning till end, you have to target for hemostasis. Say a simple example is during LSS. If there is a veins, engorged veins over the front, over the line of incision, you just place a ligature, ligate it below and above, and in between you cut it. And angle, securing the angle where the bleeding is more important, that you do it. And in the angle, if the uterine, if the artery is affected, you ligate it separately, then you start from the angle. Many people, what they do with the angle, with the muscle, with the artery, they combining that. So these are achieving hemostasis. I have already told about this tips and tricks of cesarean section, the angle, preservation of that, and few of the hemostatic sutures, additional hemostatic sutures when there is a bleeding should be there, so that hemostasis has to be maintained in whatever it may be. Then compression suture, Bill Lynch was innovative in finding out the compression suture, and there are various modifications after Bill Lynch also across the country. When he started Bill Lynch, he started with 7 cases only. Now lakhs and lakhs of cases of compression sutures have been devised, and various methods like Cho's method, modified Bill Lynch method, all these methods are there for that. But compression suture also helps that. But I believe, I give a caution here. People nowadays, we find that there is a giving a overemphasizing this compression suture and overusing the compression suture. Believe me, with frank confession, I can say, I am yet to use one compression suture in my life, although there is a lot of, because I always believe prevention, and the medicated, the ecbolics has to be given a right dose, and gentle tissue handling and management will serve the purpose for that. And I don't repent by not doing a compression suture in future. So I have seen many people have overemphasized that, but there is a need. I don't discard that. There is a need for that also. But unfortunately or unfortunately, I didn't have a chance to apply that, because I believe that 99.9% of the PPH are created by us. So mishandling and rough, I think mismanagement during the time of cesarean section and third stage of labor is the main cause of PPH for that also. You don't have a patience, you just may do it how much, looking at the watch, you just as quickly as possible finish the cesarean and then go. I think this is a wrong principle for that. You pack, press and pray. Allow the time, give an ecbolics, hand over the baby, give an ecbolics. Don't do manual removal of the placenta, all cases for that, just to finish it quick. That will provide more of bleeding for that, and ultimately landing in PPH, in cesarean section. So therefore, pack, press and pray principle, apply that, allow the uterus to have a contract, and this is a living ligature. Once the uterus is contracted, nothing like it. And there are very efficient styptics available, starting from, we are in the earlier time, we are having methargin, we are having a syntocinon, now the carbetocin is there, syntocinon is there, effective syntocinon is there, and prostaglandins, the misoprostols are there, endoprost are there. So all these products are there, particularly for the. So therefore, this is compression suture. Then another method is a stepwise devascularization. Yes, it is a method, stepwise devascularization. Uterine, ovarian, bilateral intrailiac ligation for that is important for that. There is a place definitely for intrailiac ligation in some indications for that, particularly if there is a rupture uterus, extension to one particular unit, or a supraelevator hematoma. They are unilateral. The ligation of the intrailiac is really rewarding for that. If there is a generalized oozing, there also bilateral uterine ligation could be of help for that also. But simply, there are a lot of studies where you say that for arresting PPH only, bilateral internal ligation, how many percent? That varies from about the incidence, the success rate varies from 12% to 40% only. So these are some of the various issues which is associated with the bilateral internal ligation. Don't think that it's the only method which is available, but appropriate method and appropriate timing is important, which again I emphasize. If you find that it is best to use the hysterectomy, it should be as the first resort for that. If it's a multiparas, bleeding is more, morbidization, immediately the first step should be going for a cesarean hysterectomy, then a stepwise devascularization procedure for that also. And therefore, the hysterectomy, peripartum hysterectomy is a life-saving procedure, which I have already communicated to you earlier and emphasizing today also. Now, traumatic PPH. Majority of people believe that all PPH are supposed to be ectopic. That's not true. Traumatic PPH, surgical management of rupture uterus, very, very important for that. And whether you are going for a repair, subtotal hysterectomy or a total hysterectomy, there are various indications for that. If the repair of the uterus post-cesarean rupture or post-myomectomy rupture, if there is a clean-cut wound, you can have a repair. And the timing is important. In a moribund patient, when there is a patient is in shock, you have to find out that as quickly as possible, we do it so that the patient is not on anesthesia for a long time. And therefore, the indication is there from total to subtotal as a life-saving. And therefore, there is a place today of subtotal hysterectomy also just for time's sake. But if it is a placenta occupying below the level, I think you go for a total hysterectomy. It's not possible to do a subtotal hysterectomy and manage the result for that because the bleeding will be there. So therefore, the surgical management of rupture uterus, one should learn it and very meticulously but aggressively with a skilled hand, it should be managed with that. Simple cervical tear, vaginal tear. People have died because of that, because of non-interference. I think cervical tear, the tips and tricks, it could be done. If it is not visualization is not perfect, you do it under anesthesia, always under anesthesia. Good lighting should be there. Good assistant should be there to retract. Speculum should be there to retract. Don't compromise with that. And unless we hold the cervical lips correctly with the sponge holder and see the apex, then it will not be a quality repair for that. And remember, emphasize for that, you have to see the apex and suture it appropriately. It's not a big deal for that, but the exposure is important, anesthesia is important. Same thing with the vaginal tear. When it's not approachable, I think the long extended tear in the vaginal tear, you are not able to approach the apex. You gradually put a ligature, then drag it and put it above it. Gradually from below above, you just find out. But in many cases, you may be required to do it under anesthesia because without anesthesia, a difficult case cannot be done. The depth of suture also is important because if you find, I have seen the vaginal mucosa, a little thinner layer, if you get below it, there could be a collection for that. So not too deep, not too superficial. You grab it, whole thickness where it is tear is there, you just grabs it and either continuous locking, you do it, or interrupted, you do it, choice is yours. But a good approximation of vaginal tear from beginning till end, from the apex till down, you must have it for that. These are all very important tips and tricks. Very simple thing, anesthesia part, exposure part, lighting part, and the retraction and the assistant, all are important. Perineal tear also, the tips and the primary perineal tear repair is important because if the repair of the primary perineal tear is good, there is no need of subsequent very challenging situations of anorectal dysfunction. Prevention and management of vulval hematoma. Again, if they prevent it, it's good because a good episiotomy is a very small operation. Don't take it lightly. It is a very important operation. It needs a plastic sense. It may give rise to a lot of complications for that. So prevention of vulval hematoma, I have already told during my previous episodes how to deal with that. Supralevator, infralevator, and the various vulval hematoma, the diagnostic protocol, and the management, how to suture it, the vulval hematoma, and approach from below or from above. I have really dealt with it. So this is a B-Lynch uterine compression suture where you find it go through the below and then come to the fundus and then to the opposite side, another fundus, and then come inside. So these are the cases where the B-Lynch uterine compression suture is very important. There are various modifications of the suture so that the sleeve, the fundal sleeve is gradually, there is a tendency to slip, and therefore the Chow squares method or the modification of the B-Lynch has been accepted for that also. This is the area where the interiliac ligation is there. Remember, the anterior division of the interiliac should be there, and posterior branch supplies the various vital and the posterior aspect. You leave it as such. The anterior division, you just find out the anterior branch of the interiliac artery and ligate it at an appropriate. It's not very difficult. You start it tracing it from the common iliac, and it's very easy to find out, trace it. If you go external iliac, you can find out, and internal iliac, you can find out. Internal bifurcates into the anterior division and posterior division, and the anterior division, you just ligate it, and that and take precaution of the ureter not involved, because ureter doesn't come in view, but ureter is the medial aspect. You just retract and find out, but it's not very difficult. People say that it's a very difficult surgery for that. It can be done for that. Uterine artery is much more simple for that, but the uterine artery, remember one principle, that you don't isolate or skeletonize the uterine artery. You don't skeletonize, but take a little muscular tissue along with the uterine artery, because in the lateral aspect, and don't go much below, because the ureter is going to be involved in that. You at a little higher level, little muscular tissue involved, and bilaterally you can tie with that. These are all stepwise devascularization of the step 1, step 2 cervical vaginal artery, then the ovarian artery, anastomosis branch of the ovarian artery, and then hypogastric artery for that, the stepwise devascularization. These are all uterine tamponade, various modifications starting from Bakri balloon to the condom to the various indigenous methods are there also with the uterine tamponade, but this could be of help, particularly in desperate situations for that. And this I will tell that yes, our panicker has devised that. She has told me, convinced me that this is a thing which you use it for that, suction for PPH instead. But again, I can say with humility that I'm not getting chance to use this as a case, so that I cannot get my share, my experience with all these procedures. Neither compression suture, nor the PPH instastop, nor the internal leg for the other indications I've got it, but for PPH, I've yet to find out for that. Now, clinical situations. The next part is the clinical situations, and finally we'll end with the video presentations. There are some real life stories which always I want to ventilate with you so that you can learn much better with that. And this is one of the situation one. Let us start with that. It's a 27 years para 1, underwent LLTZ, large loop excision of the transformation zone, presented with acute episode of bleeding on 8th post-op day. On examination, general condition is stable, tachycardia, perspeculum cervix minimal slough with active bleeding from surface. So what is their approach? Normally we say that yes, medical management like a tranexamic acid, and if there is a bleeding is more, you give a vaginal pack, antibiotics because of the infections, and then after removing the pack after 24 to 48 hours and discharge after 48 hours and on even full recovery. So these are the cases where such things are very common, not only following the procedure, but all cervical minor procedures, like even cauterization, electrocauterization service. If there is an alarming bleeding, then packing is there. Otherwise, don't need a packing. Just medical management is enough. Amputation, LLTZ, or tracheography. I have faced few cases in that because, and there a majority of the cases, they are really all right with medical management of tranexamic acid, or at best, if there is a more than moderate to severe bleeding, we can give a pack for that. And most often managed by medical management. Need for vaginal packing can be there in some cases. Secondary infection and sloughing are the major causes of this particular thing. 38 years, recurrent endometriosis. History of previous surgery, 3 occasions. Laparotomy and abdominal hysterectomy planned elsewhere for that. And patient was 38 years. The adenomyosis on sonography and previous endometriosis. Couldn't, but they have opened it, but they couldn't enter the peritoneal cavity because of the extensive adhesions, and therefore they have referred back to me. I have planned for surgery. I was really skeptical also in this particular case. In this particular case, I always become skeptical, and I always say that their experience usually the surgical skill will be demonstrated. I always say that middle level gynecologists, those who have practiced for 10 to 15 years, be exposed to this type of cases. Your surgical skill will improve with that, because there is a lot of risks, a lot of challenges which is involved in this type of cases. And plan for surgery, then I decided para-abdomen suprapubic scar was there, uterus 14 weeks, PV 14 weeks, palm restricted mobility, and sonography is a diffuse adenomyosis with chocolate cyst ovary right. Choice of, now question comes, choice of incision and arrest of hemorrhage. These are the 2 things. But as a benign gynecologist, I'm not a malignant gynecologist, so that I will go for a larger incisions for that. And from the symphysis pubis till the giphisternum, I can't do it, but I have gone to that incision. Even with little difficulty, I feel that surgeon's inconvenience is directly related to the convenience of the patient. And therefore, even if it's required, exposure is less, I will do a muscle cutting, there is no problem for that. But still, I have gone to that choice. But arrest of hemorrhage is very important. I can arrest, I can block the vessels by the vessel sealer for that. But the generalized bleeding is more often in here. Injury to the rectosigmoid is more often here. So suprapubic incision, given difficult entry to peritoneal cavity to adhesion, but go slow. Use a vessel sealer, completed the procedure, and there was a generalized oozing after the hysterectomy is being done. There was a generalized oozing from the posterior surface, the rectosigmoid, the bed, and the lateral pelvic wall. There was absolutely generalized oozing for that. And I deal with the pressure. I always say that these are the cases where do a pressure, keep it for 5 minutes with the mop, and then absolutely all right. And in cases where you find a selected point, the bipolar has to be used. But be cautious. Bipolar over the bowel or over the rectum, that can be dangerous for that. So therefore, you select the site and tackle that situation. If the lateral pelvic wall, if there is away from the urethra, you can use it. Bipolar, that is not a problem. But believe me, pressure is the best tips and tricks which is important in this type of generalized oozing for that. It's not the drain which is matters for that. It's only the arrest of bleeding. Once you're convinced that there is no bleeding, then you close the abdomen. Don't, many people say that there is a bleeding, we'll put a drain and then come out. No, don't say that. I totally disagree with them. So message is bleeding expected in such cases. It is expected. Electrosurgical device can help in bipolar. Place of mechanical pressure, immense value. Then again, I'm giving you that this is immense value. And drain is a very questionable mark for that. 44 years, multiple myoma uterus, HIV positive, long back. When in my earlier years of when I was an assistant professor, this was a case. I still remember. I cannot forget the face of this patient. 44 years, multiple myoma uterus, HIV positive. So there are, when there are HIV positive, everybody escape. No surgeon will try to involve in that. So I told my professor, we'll do it, you do it, I will assist you. And she agreed for that. HIV positive, underwent abdominal hysterectomy. Presented on 10th post-op day with vaginal bleeding. Patient was stable. Perspiculum oozing from the vault. Site of active bleeder was not located. Vaginal packing, my professor did it. Styptics, antibiotics, blood transfusion. Removed the pack after 24 hours. Bleeding PV continuing for a few days with sporadic heavy bleeding. On examination, generalized oozing from the edge of the vault. Then we sutured it, bleed free for 10 days, readmitted with heavy episode of bleeding. And then we find the hemoglobin is 8 gram%, coagulation profile normal, and on examination, vault bleeding was more than average. Source could not be detected. We couldn't find out the source. And in a case where earlier the vault was also repaired for that. So therefore, we planned for exploration by laparotomy, vault made open, resutured with special reference to the vault done. Then I did a bilateral internal ligation and patient discharged on 10th post-op day. Unfortunately, patient readmitted after 10 days with one episode of heavy bleeding PB with shock. Absolutely peripheral circulatory failure, resuscitation done with fluids and blood transfusion, pressure agents, but we couldn't save the patient. Patient could not be revived. And this was very unfortunate situations. So the message, all surgical techniques of intervention failed. What is the factor? I believe I introspect myself, whether it's a physician factor or a patient factor or a tissue factor, whether the tissue is defective or immunity factor or healing factor, which is important because that's important. We take a credit of arresting the bleeding and hemorrhage. If the God has not given a power to heal the tissues, again the bleeding, how it can be done? Again it will be manifested for that. So hats off to the Supreme Creator God, which is a healing power, and we suture it and he heals it. If the healing is defective, the tissue factor is defective, the immunity factor is defective. We know that this is an HIV positive. This could be one of the cause which could be explained and give a solace. But I was really unfortunate to see this. And therefore, this type of case needs more of thinking and research why it has happened. And hence for next case, we should not face this type of problem. 40 years para 2, both LACS, AUB adenomyosis, not responding to medical management. I planned for vaginal hysterectomy because previous 2 cesarean is not a contraindication for vaginal. Uneventful intraoperative period, bladder densely adherent. This is the only problem which you find that in previous cesarean, you go through the lateral window as devised by Series set and then come centrally, because otherwise centrally if you go, the incidence of bladder injury will be more. But many cases you find bladder is densely adherent. Even if you do laparoscopy also we do, or vaginal we do, there is a difficulty in separation in few cases where the dense adhesions are there. Here, same thing, bladder densely adherent, dissected, but dissected in right plane. Patient discharged after 48 hours. Bowel bladder normal, presented with pain abdomen with strangury. On examination, per abdomen soft, sonography echogenic lesion of 5 centimeters in the vault. Urine culture no growth, on conservative management. And I didn't try to intervene this. Repeat pelvic scan after I saw that there is a bleeding from the, I think, hematoma, which is in the vault in the central part, maybe because of the base of the generalized oozing from the bladder, it has happened. And repeat pelvic scan after 10 days. The size is diminished to 2 centimeter, bowel bladder normal, but pain persisted for 2 weeks. And after 2 weeks, small hematoma in the vault. I think it's disappeared. Patient was all right after 2 weeks. So the message is small hematoma in the vault for vaginal hysterectomy, not uncommon, but the generalized oozing from the bladder base is the cause. So therefore, in such cases, don't be complacent. Don't take don't see your watch and operate. Inspect the bladder surface for oozing, and you can coagulate at the right moment. Primary surgery, and I believe that tackling hemorrhage in the primary surgery intrapartum period is very, very important for that. Don't be complacent on that. And therefore, this is one aspect in which we do it. Second is that you bring the peritoneum, and with the peritoneum and the vaginal edge, you stitch it so that the compression of the peritoneum with that little bleeding will be less, will be not be there, collection will not be there. So taking the peritoneum along with the vaginal wall helps in mechanical hemostasis. These are the two techniques, tips and tricks I'm giving you. Inspect the bladder wall. If there is a small vessel, put a bipolar. And second is the peritoneum along with the vaginal wall helps in mechanical hemostasis. This is a tips and tricks for that. 29 years primary infertility is a great for endometriosis, plan for lap surgery. And therefore, pre-op planning, this is important. I was confused. There's a challenge, surgical challenge. Interrupt techniques to arrest bleeding, we must provide. And to arrest bleeding, a preventive aspect, need for pre-op GnRH analog. In these cases, pre-op GnRH analog will help in reducing the bleeding, hemostasis. That's very important, which I'm always in favor of that. And the tissue planes will be much better. The cystectomy will be much better. You can do the surgery very well for that. So there is a need for pre-op GnRH analog. Place of 3D endovision. 3D is a mandatory, which I believe if you're going for laparoscopic surgery in this particular case, 3D endovision is a mandatory thing because vision is very important. Place of local vasopressin. You inject the vasopressin into the posterior surface of the uterus and or in the infundibulum pelvic if you find it. But the posterior surface of the uterus, as low as possible, you inject it, and that will help it in the clearance of the POD. Then place a bipolar. The bipolar vessel sealer is important as a vessel. If you compare, there are in energy sources, particularly in the power, we have got various ranges. The bipolar forceps, the vessel sealer, the harmonic. And out of which, the harmonic, the hemostasis is lesser than the bipolar. The bipolar as well as the vessel sealer have a very good vessel sealing capacity and hemostatic function for that. If you are using the harmonic, if you're going for a low set setting, 3 and 5, if you go below it, 1 or 2, that helps in hemostasis much better for that. So therefore, in low setting also, harmonic can act much better. And there are various other forms like shear and all that, which helps in coagulation and cutting also. There could be intermediate. So you can use, as per your discussion, the place of power, whichever is helpful for you. But the tips and tricks of each equipment, you must understand what are that. And that is important. Some of the biomechanics and engineering part, you as a medical faculty should understand the use of your instrument, and that is much better for that. And therefore, this laparoscopic surgery is mainly dependent on this particular energy sources, and right application of the energy sources in the right plane is important. And don't overuse it also to damage the whole of the ovary, to create problem of the adjacent organs by damaging this thermal injury. So role of local sealants is also there here, local gauge and pressure. In laparoscopic surgery, I think the gauge and pressure in open surgery, you can press it for 5 minutes. But you can put a small gauge into the laparoscopy and particular part, you just keep it. Suppose there is a oozing in a particular area on the lateral pelvic column right side, you put a gauge on that particular part and press it with the with your hand instruments and keep it there. And then subsequently finish the surgery. And by the time you complete the other side, you remove the gauze and then things will be okay. And the gauze is also acting as a very good hemostat. We know from the beginning, understanding of the coagulation profile. Now, the pressure effect. The place of intraperitoneal drainage is least. Place of intraperitoneal drainage is least. I don't give an importance to the drainage, but give an importance to the primary arrest of the bleeding. So the message, pre-op planning and preparation adds to prevention of hemorrhage. Local vasopressin helps. Vision is important not only for visualizing the bleeding points, but also prevention of injury to other nearby structures. Bipolar is preferable. And understanding the do's and don'ts of bipolar is important. You don't apply it on vital structures or over the surface where the overlying the ureter, overlying the rectosigmoid, and that is there. Pressure by gauge and local sealants ancillary help it, and systemic tranexamic acid helps. Drain is of doubtful value. 46 years underwent lapistectomy for multiple myoma uterus, discharged on third post-op day. Presented with acute onset of severe bleeding, tachycardia, hypotension, tachypnea, resuscitation started, abdomen soft, evidence of peripheral circulatory failure, active bleeding PV, planned for exploration under anesthesia. I planned it. When I put a speculum, there was a clots in the vagina which was removed, and when I find the whole vault was open and active bleeding from the margins of the vault found to be open completely. So I repaired the vault with hemostasis. Patient was discharged on third post-op day. So the message is post-op hemorrhage following hysterectomy, not uncommon. Usually there's a very majority of the cases, they present with small bleeds for a few days and they don't need a surgical intervention. And they're controlled with styptics and antibiotics. Mainly this is because of the infection, hard stool, or excessive physical exercise activity. So only concern is a massive bleeding of acute onset. There immediate surgical intervention is required, and that is important. Otherwise, routinely it is not required in all cases, but majority of the cases you must be facing small amount of bleeding for a few days, and that is it. But the massive bleeding of acute onset is a rare presentation, and this particular case is a rare presentation. Her husband was in Dubai. He came after receiving the news that the wife is operated, and on 10th, 14th day he came, and because this is because of the sexual act for that, and unfortunately it is a preventable thing for that. When I took a history, I found that this is because of that. Immediate exploration repair with hemostasis will save life. Otherwise, I would have lost this patient. And of course, this can be very well managed by vaginal approach. Is feasible, but under anesthesia you do it. And post-op counseling and advice. Therefore, in all hysterectomy, you do a post-op counseling and advice necessary for that. And therefore, PAC is not the solution. It is the identification, local exploration. By speculum, you find out a specific area of bleeding and then immediately suture it and hemostat. 50 years para 2 underwent hysterectomy with pelvic lymphadenectomy for carcinoma endometrium, presented with bleeding PV for 5 days, 2 weeks following surgery. Hospitalized, patient stable, abdomen soft, perspeculum vault healthy, small blood stain discharge from right angle of vault. Styptics, antibiotics given, having multiple episodes of bleeding within 48 hours in the hospital, planned for exploration under GA. Because there was bleeding was not controlled, I planned for that. EUA perspeculum vault was healthy, no slough, but active bleeding from right angle of blood was there. But no, we cannot find out the source where this, the exact source is not identified, and therefore I planned for laparoscopic approach. On laparoscopy, I find that no interpretation bleed is detected, moderate adhesion in pelvis, adhesion since right angle of vault with vascular mass of 5 centimeters in the right angle. When I tried to dissect this and managed with the laparoscopy, there was a torrential bleeding from the vault angle on dissection, but source could not be detected. I didn't hesitate. I sacrificed. I don't have an ego. I sacrificed it. And then I did immediately jump to laparotomy to save the patient. Laparotomy done, active bleeding in the angle identified, sutured, small bleeding from the edge of vaginal valve sutured. Hemostasis were maintained and discharged on 5th post-op day. So message is, delayed manifestation could be due to infection, but appropriate route and method to be decided to tackle hemorrhage. Saving life is the first and paramount importance, and you must manage this and surgical. There is a need for surgical intervention here. P1A1 underwent suction evacuation. Very interesting case. Para 1 abortion 1 underwent suction evacuation for 10 weeks pregnancy, had post-orbital bleeding, and repeat evacuation 2 times has been done. And even with that also, patient came with bleeding, presented with acute episodes of bleeding, many occasions, 4 weeks following the procedure, and then referred to me. When I examined, clinically absolutely normal. Sonography also normal. There is no evidence of retained product of conception. Beta ECG was normal. These are the cases where you think of GTD. So beta ECG was normal. and therefore I planned for diagnostic hysteroscopy. When I did a hysteroscopy, cavity was normal, no space occupying lesion, active bleeder from right lateral wall. I could find the source of bleeding from the right lateral wall. There is a twig which is spotting. And then I coagulated with a roller ball. Roller ball I coagulated with the blend current, and pediatric Foley's tamponade was given. Patient was discharged, again readmitted with another heavy episode after 1 week. And therefore, I didn't again venture to do again a hysteroscopy. I thought of that. This is definitely a uterine artery, a branch of uterine artery, which has been in the medial aspect into the cavity for that. And that I have diagnosed it with the hysteroscopy. And therefore, I have planned for laparoscopic approach and ligation of the right uterine artery. And I did a laparoscopy, ligation of the right uterine artery, which is very easy. Patient had uneventful recovery for that. And therefore, the message, post-orbital bleeding is not uncommon. Subsequent to RPOC and GTD are common, but this is an atypical presentation. The very atypical presentation, I could find the bare uterine artery in the cavity, branch of the uterine artery in the cavity, which is not being tabled by the hysteroscopy. And these particular cases, even if you use back coagulation by hysteroscopy, again after some time it will slough and it will give way. So that we did a laparoscopic approach and ligate the right uterine artery separately along with the muscle, and patient was absolutely all right. And in this particular case, what is the option? Alternative option is you can do a uterine artery embolization also. Is an alternate option for that for surgery. Mrs. Y, 25 years, primary infertility, 5 years, planned for DHL, his diagnostic hysterolaparoscopy, DH cavity visualized and immediately collapsed. Rent suspected. These are the cases where rent suspected. Visualized and confirmed by laparoscopy, and it was a fundal perforation. Dye test was fortunately possible by mechanical plugging. I could do the dye test, gentle coagulation, bleeding control. So these are the cases where perforation could be there, but you can be able to diagnose. Missing the perforation, which is very delicate. Here we put it, as soon as your hysteroscope is there, you cannot see anything, then you suspect that there is a perforation for that. The pressure, the intrauterine pressure was not there. And therefore, this case, we put into laparoscopy and find out that yes, there is definitely a rent for that. Again, see that we cannot see these collapsed because the pressure was not maintained. This is a way to diagnose perforation, and immediately the laparoscopy you put it and find out that yes, there is a perforation in the fundus and little bleeding was there. You just irrigated that. This is the dilator which has gone inside, and with the bipolar, simple bipolar, you coagulate and rest in peace. You would have a otherwise, you will have a sleepless nights after that if you go for a conservative management for that without looking at that. So therefore, in this particular case, the endoscopy procedure, the laparoscopy has helped along with that, and simple coagulation with that rent is absolutely rewarding for that. 43 years, para 2, both spontaneous delivery, AUB, adenomyosis, planned for vaginal hysterectomy. Vaginal hysterectomy was done under spinal anesthesia, but 12 hours following surgery, patient developed tachycardia, hypotension, blood pressure was 80/50, abdominal distension and pain abdomen with pallor. Nothing that is revealed. I think it's a concealed hemorrhage. It's an intraperitoneal bleed, immediately subjected to laparoscopy. And on laparoscopy, hemoperitoneum was found, blood and blood clots removed, active bleeder from the right pedicle, partial slippage of suture was there. In that area where before the vessel sealer I was using the suture and there was a partial slippage of suture, bipolar coagulation was done, hemostasis maintained, post-op uneventful. So these are the cases where post-op internal hemorrhage is a preventable event, but you should be very meticulous during the intraoperative period, and that's important. Meticulous surgical technique with special reference to hemostasis during the previous surgery is very, very important. I will blame myself in this, why there is a slippage of the nut in the top pedicle. That slippage of pedicle suture from the upper pedicle is the cause of bleeding, and therefore I prefer that better is vessel sealer. The sutureless is much better for that, and I have never faced this with it. Early diagnosis, clinical suspicion, and emergency intervention is the key for that. Many some cases, one case I remember, these cases vaginal hysterectomy has been done, and then the patient was having internal bleeding, and when We put a laparoscopy. We cleaned it. We didn't find a source of bleeding also. So wherever is there is here the one case, I have seen that there is a bleeding from the pedicle, but there the pedicle is absolutely normal. After peritoneal toileting, not a single pedicle is having a bleeding, and patient was discharged subsequently. And these are the cases where maybe that initial bleeding was there, it is arrested, but because of the moderate amount of collection, we had to do the laparoscopy procedure, and otherwise the postoperative morbidity is there. But believe me, you may find in some occasions that on exploration also you may not be able to find anything. Just peritoneal toileting and clean it, then you'll repent why I have again done the surgical experience, but it will pay you. 26 years primary, underwent elective cesarean section for torn breech after 12 hours. Features of peripheral circulatory failure, tachycardia, hypotension, tachypnea, pallor, cold clammy skin, abdomen distension. So they called my help, and I went there to that hospital for help, called for help, because the initial surgeon was not there, and he has gone somewhere after the surgery, and immediately I was called because of the emergency, and I advised for immediate exploration with the requisition for 2 units of blood given. Then I opened up, exploration was done. I find massive intraperitoneal collection of blood. Toileting, I did a toileting. I was thinking that the bleeding could be from the uterine wound, but uterine suture was absolutely normal, hemostatic. But there was a small pulsatile twig from the edge of peritoneum in the UV space detected, coagulated, and abdomen closed in layers, post-op blood transfusion, uneventful recovery, discharged on 7th post-op day. So the initial surgeon doesn't believe in the position of the peritoneum, peritoneal closure, is in favor of non-peritoneal closure, non-closure of the peritoneum, but is not given attention to this small twig, small pulsatile twig. It's a very important thing which I find, and therefore the message is post-op intraperitoneal bleed, not uncommon. Early recognition and surgical intervention saves life. A typical case of bleeding from the UV space rather than from the uterine wound. Normally we expect that it will come from the uterine wound, but rather than the uterine wound, it has come from the small twigs in the peritoneum. So there are two views. Many people do close the peritoneum. Many people do not close the peritoneum. I always close the peritoneum for that. And even if you don't close the peritoneum, the non-closure group, acceptable. But at least visualize, at least hemostasis should be maintained in each step for that. And this is a lesson from this particular case. G3P2, 35 years post-cesarean pregnancy at 18 weeks. Attempted termination of pregnancy elsewhere, failed. Presented to me with bleeding PV, sonography, single live fetus, 17.6 weeks, absent liquor, placenta low-lying, and therefore I planned for hysterotomy. Lower corpus and cervical ballooning with engorged veins were found when I opened up, and therefore then when I did a hysterotomy, torrential bleeding from the edges, placenta morbidly adherent to cervix and bladder, total hysterectomy with excision of bladder wall was done, and to save the life. Bladder repaired, hemostasis maintained, patient discharged with uneventful recovery. It's not the question of cesarean hysterectomy. In earlier weeks also, this could be seen. That's why I presented this particular case. Placental location, morbid adhesion, diagnostic accuracy by ultrasound. Therefore, again, I'm repeating, wherever in ultrasound we find a low-lying placenta, morbid adhesion should be ruled out. Resort to hysterotomy rather than alternate. Don't try for alternate methods, even if it could be possible alternate methods of giving some drugs, misoprostol, other things. That will fail. That is not a method for that. Decision for hysterectomy in such cases saves life. Paravan LSCS 4 weeks ago had bleeding from the middle part of scar 10 days following operation. Not controlled with the dressing and styptics. Consulted the surgeon. Exploration and drainage of blood from the parietal wall through the center of the scar under local anesthesia done. And it was relieved for 1 week, but the patient was having a persistent bleeding from the wound and then referred to me. And when I examined, I find wound induration. There is a moderate wound induration in the suprapubic area, and I did a sonography. There is a mixed echogenic lesion of large 10 to 15 centimeter below the scar and volume about 280 cc, and therefore I planned for exploration under anesthesia. I planned thorough exploration on it. Not that earlier the surgeon has just given incision, drainage, and sucked it out. I didn't want that. And when I find exploration, large hematoma below the rectus sheath, it is below the rectus sheath and rectus muscle. It was drained, mopped out very well. Small twigs were coagulated, drain given, patient uneventful recovery and discharge on third post-op day. So message is hemostasis in surgery at every step is very vital. It's not the intraperitoneal. The closure in the peritoneal parietal wall also is very important. And small twigs, be very clear that always what happens in transverse incision. No, everybody give a special attention below the rectus muscle. Below the rectus muscle, you just lift it and find out whether there is a small oozing or bruising there or not. If there is a bruise also, coagulate it, and that will prevent this. Routine inspection below the rectus muscle and angle and coagulation is very important. No place for complacency. 28 years, second gravida, para 1 at 30 weeks gestation, presented with bleeding PB since 10 hours. Sonography, single live fetus, 30.4 weeks. Placenta was fundal. No retroplacental clot. Hospitalized. This is a case of FPH, but no retroplacental clot. Placenta was fundal. Conjunctive management was given as per FPH, indeterminate variety. This was level as an indeterminate variety of FPH. Tranexamic IV fluid started, but bleeding continuing. When the bleeding continued, I put a speculum. Per speculum, blood clot from the vagina, removed, no bleeding from the os. But there was an active bleeding from the posterior fornix. And I detected a transverse tear of 3 centimeter length in the posterior fornix with active bleeding from the edges, repaired, bleeding controlled, patient discharged the next day. So this could be another case of FPH. People think that it's a case of placenta previa or placental abruption or indeterminate variety, but this is not uncommon. Sonography, essential diagnostic gadgets, indeterminate variety accounts for 15 to 20%. Trauma, postcoital trauma, a rare cause, but it could be possible. Relevance to clinical examination. Don't ignore in the high-tech gadgets. Don't ignore your clinical sense. Relevance to clinical examination, important in addition to the gadgets. G3A2, TCR is done. Transcervical resection of septum. Septum resection done for subsepted uterus. Regular ANC. Presented with pain abdomen at 27th week. Uterus was 28 weeks. Tender. Cervix long. Os closed. Sonography revealed single live fetus 27.2 weeks. Estimated birth weight was 800 grams. Under observation in the hospital with analgesics, toccolytics. After 24 hours, pain abdomen aggravated, and on examination, pulse rate tachycardia 140 per minute, BP 80/60, abdomen distended, tender, uterine contour not felt. So immediate laparotomy was done. There was a massive hemoperitoneum, fresh stillborn male fetus and placenta in the peritoneal cavity. There was a transverse rupture of uterus in the fundus with active bleeders. Fetus and placenta removed, peritoneal toileting done, repair of rent in double layer with hemostasis, 2 units of blood transfused, uneventful post-op recovery. But patient was depressed, I was also depressed, counseling done. Maternal life saved, but motherhood shattered because of this particular case. So this is a consequence of the septal resection. This occurs, rupture occurs, and particularly be very careful to undercut rather than the overcut. She came for post-op checkup after 6 months, very much keen for conception, counseling done for surrogacy adoption, but presented after 1 year with early pregnancy, risk explained of subsequent rupture, but insisted to continue pregnancy. Regular ANC with warning signs of possible rupture. At 32 weeks, I did an elective CS, done after glucocorticoid, preterm male baby of 1.8 kg delivered, kept in ICU for 5 days, and baby and mother was very good and discharged. Uneventful intrapartum postpartum period, and left the hospital with happiness for that. So the message, risk of possible silent rupture following septal resection, meticulous technique is required. Diagnosis during pregnancy, sonographic pointers, we couldn't get it. Warning signs to be conveyed, more frequent antenatal care, early recognition and immediate surgery may save life. Management of subsequent pregnancy, a challenge. Early delivery, balancing the fetal maturity will save maternal as well as fetal life. And this is a lesson to be learned for future. This is a case which I will cite during my post-graduation. During the time of post-graduation 80s, para 1 with jaundice, viral hepatitis, delivered a torn female baby with vaginal route with mediolateral episiotomy with mild PPH. Controlled with ecbolics, had continuous trickling of blood, coagulation profile normal, uterus contracted, vitamin K given, blood transfusion, 3 units she has got it. Mild bleeding PV continuing on second day. My professor came and round and professor advised hematological profile, repeated normal. He advised for vitamin K, repeat dose, and he advised a new drug has come like Botropus. He told that you give this injection Botropus. This is again a biochemical thing, which is a styptics, Botropus, and blood transfusion to continue. So I was a first year postgraduate during that time, and curiosity came to me. People thought that yes, it's a jaundice. Bleeding is obvious. Bleeding is obvious. And I did a speculum examination during my emergency hour. And when I did an emergency hour speculum examination, found a bleeding point in the apex of the episiotomy. I stitched it without informing the RS. And bleeding controlled, patient stable. Next day, my professor came, and the professor and Botropus took the credit. But reality is different. Later on, when the professor knew that this thing has happened and I had done that, he called me. He felt ashamed and he learned a lesson. And therefore, I told, he was very happy with me. And he told, what do you want? I told that I want a first chance, MD clearance in first chance and PG in first chance. Patient had uneventful recovery. What's wrong? There is a fixed idea. Dogmatic views and complacency is the factor for that. And therefore, the message learned from this case. Prefixed idea is fatal in medicine. Methodical treatment has its own place. One has to learn from anybody. 23 years, para 2 vaginal delivery. Full-term male baby, Apgar score 8/10, had severe PPH after delivery. Aquabolics given, blood transfusion arranged, bleeding continuing, vitals falling. So decision for emergency hysterectomy taken, and that hysterectomy was performed with no time, but yet bleeding PV continuing. And therefore, I was operating my routine case hysterectomy on 1 OT. The emergency OT, one of my assistant professor was doing the surgery. Then he called help. Sir, you come and see. Even if I did a hysterectomy also, patient is bleeding. So when I went there, I put a speculum, revealed a lateral vaginal wall tear with active bleeding. Sutured vaginally, but patient had a cardiac arrest and could not be revived. We lost the patient. Is it the bad luck of the lady or bad hands of the obstetricians? Everything you think that it's a case of atonic PPH, and this is a case of traumatic. All PPH are not supposed to be atonic. That's a presumption only. Brain should be active while hands are hyperactive. Guidelines has to be followed. Introspection for future required. Don't blame the luck. Blame yourself. Now the last part, we'll have some surgical videos. Sanjay will have some surgical videos. This is an abdominal hysterectomy. This is an abdominal hysterectomy, abdominal myomectomy. So abdominal myomectomy, we say that there is a place of the uterine tourniquet. Uterine tourniquet is being applied here, and you can use the vasopressin also, but this is an option where uterine tourniquet can be applied, and you cannot do it in laparoscopy. The vasopressin is a must in that particular case, but in laparotomy, when you are doing it, provided the area is very free, you can apply. You cannot apply if there is a cervical myoma. If the cervical part is normal, you can apply this for that. So very meticulously, by you open up, taking again, this is a part where you arrest the tackling the bleeding which should be there, parietal wall. All laparotomy should be done absolutely with strict hemostasis. Even if you open it, you do it with the strict hemostasis for that, and then you go and enter it. And this is the large myoma. The large myoma, I delivered it with the vacuum. This is a vacuum from obstetric practice to gynecological practice. I shifted that. So you can deliver the uterus, large uterus through the vacuum, and then do a myomectomy and do a tourniquet for that. So this is how you can deliver it, or you can deliver it by myoma screw also. But myoma screw is that causes a little more of bleeding and cumbersome and messy affair for that. And therefore, this is very good that if a fundal myoma is there, and it can be delivered by pressure, traction, counter traction, and all that. And this is a large myoma, but the incision is very small. The Pfannenstiel incision, modified Pfannenstiel, but at last, we can deliver it. Yeah, this is delivered, and this is a large myoma anterior wall, and you see the cervical part is very clear, and we are planning for a tourniquet. So the feeding tube number 10, this is a feeding tube number 10. We'll introduce it and on both sides and doing a tourniquet for that. You just find out on the lateral aspect, find out an avascular space lateral to the uterine artery from below, and now you find that yes, you go it from that. So I have this side, on the right side I've done that, and again on the other side we'll have that, and the other side you again find out a very avascular space lateral to the uterine artery, and then you can do that. The other side very meticulously you can find out, and below the just lateral to the uterine artery, and that is important. Otherwise you can puncture the veins for that. And number 10 feeding tube is really very good for that. And this is the posterior aspect. In the anterior aspect, the uterovesical fold of peritoneum and UV space, and here we just put it, the ligate it. This is how the tourniquet, uterine tourniquet is there. One is clamp. Earlier they were using it. There is too cumbersome. So I always prefer to use this, provided the space is there. If there is a cervical mama, you cannot do it. But believe me, by using this, you need not give the vasopressin for that, and do the procedure of myomectomy very well for that, and complete the procedure. And then after that, you just remove it. And here we find that absolutely bloodless myomectomy can be given for that. Now, this is a case of adenomyomectomy, laparoscopic procedure, where again vasopressin is given, and after vasopressin, you just do an incision so that the bleeding will be least for that. So vasopressin is very good if you give it, and laparoscopically, this is absolutely acceptable for that. And this adenomyomectomy can be done with that. This is how you give this vasopressin. This is again a lap myomectomy. This is a case of myomectomy, lap myomectomy, posterior myoma, big myoma. You just expose that, and the vasopressin usually is given the 20 units in 100 ml of dilution. You inject it, even more dilution you can give it. And many people are afraid of giving vasopressin, but this is very good. You ask while giving and infusing the vasopressin, you tell inform the anesthetist to see for the monitor whether the bradycardia is there or not. And in one puncture, don't give in multiple punctures. This is important. In one puncture, you just give it the whole 100 ml or even 200 ml, you can give it, and then do the procedure. Whole thing will be absolutely white. Can you see that this is absolutely white? And if you then you go for a monopolar hook, you can find that absolutely clean. There is no bleeding is that, and vasopressin can help. And this is one of the very important method of prevention for that. And then second important method of prevention is find out a very good cleavage, capsule and cleavage. And if you go to the proper cleavage, bleeding will be less, and the myoma can be separated very well for that. And that I also showed the process when in my episodes on dissection part for that. This is a case where this is a port side bleeding. You can find that there is while introducing the plot, there is a port side bleeding is there. And can you see that this is a bleeding, which I have already showed, also demonstrated in my previous episode. And the ligation could be there, a port closure needle. This is a special type of port closure needle. Indigenous, our PB Bimal is giving this very good. I'm very happy with that. And just suture it. That's all. Now, this is a case in hysteroscopic surgery, how to arrest bleeding. In hysteroscopic surgery, either in a case of this is a case of submucous myoma, you do a myomectomy by the bipolar resectoscope, and what happens at the end, what you find in the bed, there occurs bleeding, spotting vessels, and there how to arrest that. So there are methods where the primary arrest of bleeding could be done by applying the coagulation current. With the same loop, you can apply the coagulation current and individually tackle it, or you can give a Foley's tamponade. Foley's tamponade is not as good as a primary arrest of bleeding, because you are sure that you are just coagulating that. And this is after that, you just do it. You can find that after going to the bed, you can find the small bleeding surfaces will be there, and there you touch it with that. Now it's almost in the complete procedure. The base is there because it was a grade 1 or grade 2 myoma. You have to go a little deeper in that, and after that you find the bleeding vessels. When the bleeding vessels are there, point out and just touch it. And then if you touch it after enucleation of the myoma, that will be absolutely, the primary surgery will be very good, and it's much better than putting a tamponade or Foley's catheter. Many people give a Foley's catheter following the surgery, but I think it's very good. You remove the tissues and finally they check that there is a bleeding or not. And you remember that this same instrument, you can use the either the Collins knife or the loop, which I have used this particular case. And this, there is an active bleeding. Can you find that there is an active bleeding? Just touch it. This is a method how you do it, the arrest of the bleeding. Just touch it. The bleeding, you locate it, and if you distend it, the bleeding will not be. You will relax it, then you can find. But this is a case where you touch it. The loop is touching the part, so that normally the bleeding is less. Now, doing a vaginal hysterectomy. When doing a procedure vaginal hysterectomy, we are using this adrenaline, diluted adrenaline solution, where it not only be hemostatic in function, less of bleeding will be there, but in the right space, this is there. I'm not going for the hydrodissection technique, but this is a case where I'm demonstrating the use anteriorly and laterally in the 3 o'clock and 9 o'clock position. Don't go for routinely. I do that in all cases of vaginal hysterectomy. I don't go for a posterior aspect, because the opening is much better. You can see that how it is a bloodless space. We can go to the uterovesical space where this diluted adrenaline can help in prevention of the bleeding. Again, same thing in a case of prolapse operation. This is a case of the vault prolapse, which vaginal repair, I planned it for that. And you can find that, yes, I have given that. It not only facilitates the dissection, but the bleeding is absolutely less. And this is how you control the bleeding for that. And if necessary, you can supplement it with the bipolar forceps and touch it for that. And this is a helping method. So preoperatively, this along with the bipolar, you just coagulate. There is no problem of applying the bipolar over the bladder, and you are not just superficial vessels, you are just coagulating. And then it should be absolutely dry for that. So this is how a method of arresting the tackling bleeding for that. This is again a case where the VH with PFR is a second degree uterine descent and large uterus. So these are the cases where the second degree, the long cervix and large uterus is there. It not only facilitates the space, but it is also having a hemostatic effect, so that the bleeding is less. So ultimately what I find, that in every case, the hemostasis is important. Always hemostasis to the surgeon is important. If you do a good hemostatic method of surgery, I think not only during the intraoperative period, but the postoperative period is also very good and complications free for that. The same procedure, we use it with that. Now, this is a case, I have already shown this also. There is a hemangioma in vulva. Hemangioma of the vulva diagnosed, and this is expected to bleed more. So what is the procedure you do it? Here, you just go to the proper place and mainly bank on the bipolar forceps, cilium. And if there is a bleeding vessels, you just control it and all. And therefore, I find that this hemangioma bleeds more. So you excise it. And whenever there is you use your current, this monopolar combination with the bipolar dissection, I think you can complete the procedure. And she go slowly, because these are the feeding vessels from behind. And while going it, you can find out that there is a bleeding here, and you can coagulate. You see the bleeding, and always use the bipolar forceps. Don't use the monopolar for that. You dissect it with the monopolar and apply the bipolar with that. So this is how you, from the base, you can control that and create that, yes, we are doing a tackling hemorrhage for that. So these are the, otherwise this hemorrhage will be really torrential for that. If you go and tackle absolutely this, even if this is a case of hemangioma, it will absolutely be bloodless for that. And so this is a case where I have shown you that how the bipolar forceps can be used for that and can be taken. This is a case where is a tubal rupture, laparoscopic approach, whole peritoneal cavity is filled with blood, and not only I dealt with this tubal rupture, I did a salpingectomy, but auto transfusion in this particular. I could collect 3 units of blood from the abdominal cavity and transfuse that. I took help of the blood bank people. They provided me the bottle, and our postgraduates were there. And they, at that time, there was we filtered it through the transfusion set where the filter is there, and then transfused it immediately. So one batch will be there completely dedicated for the auto transfusion, and one batch will be there for the surgery. And this is possible. This is another case where the cesarean section was done somewhere else, and I find that patient is complaining of pain, bleeding. When I find that yes, sonography, there is a CS scar, there is a hematoma, big hematoma in the CS scar. I put a laparoscopy. I found that yes, there is a scar. I opened up the UV space. I cleared the hematoma, clean it, and then sutured the edge, and then patient was absolutely all right for that. This is again a case of previous 3 cesarean with placenta previa, and it was a morbidly adherent placenta previa. It was diagnosed earlier, so I've given a caution. Arrangement of blood was there also, and I was expecting this. She was about 35 years also, so I counseled that I will do a hysterectomy beforehand. And it was a case of central placenta previa with IUFD and intrauterine fetal death. And you can see the placenta, the amount of bleeding which is there, and patient was diabetic, and because of that, the IUFD was done. IUFD was there, and at 34 weeks it was there. But I briefed it initially, showing the sonography report of morbid adhesion with the color Doppler. I said that is but IUD with the low-lying placenta, major irregular placenta previa. These are the cases where I plan for cesarean hysterectomy. So the procedure of cesarean hysterectomy, be very meticulous in that. And when I find that the whole the uterus is there, the flabby, the whole placenta is in the lower uterine segment and adherent, and it has gone to the bladder also. While dissecting the bladder, also there was a bladder injury, which I repaired it subsequently after the hysterectomy for that. You see the placenta, how it was adherent for that, but very, very meticulously and quickly you do the hysterectomy for that. And this hysterectomy was done. And these are the cases where I don't want to, 35 years previous to 3 cesarean with this placenta, with this amount of bleeding. I think don't venture, don't think of uterine artery ligation or internal iliac ligation. I don't think of that. So straight away go for hysterectomy so that the life is saved. So no question of internal iliac ligation, no question of compression suture, no question of suturing the bed in this particular case. So I immediately went for the hysterectomy, cesarean hysterectomy. And cesarean hysterectomy can be done. And here the bladder was completely adherent, and there was a rent also while cutting it. There was a rent, and of course this is a rent which subsequently has to be repaired for that, and patient has not even full recovery after that. So this is how you do the procedure. Don't you individualize this particular case and do a hysterectomy for that. And here there is no place for, I don't think there is a place for the vessel sealer. You go for a suture because these are all friable tissues in the pregnant uterus. I always prefer a suture in this particular case, but very closely preventing the ureteric injury, and at the lower level, upper part, there is not a problem, but at the lower level, as you go down and down, there is really a surgical challenge where you could do meticulously protecting the ureter and complete the procedure of doing a total hysterectomy. Don't do a subtotal also, you do a total hysterectomy for that and pack it, the bleeding point with the press defect. So these are the cases where many people think that yes, we'll do a uterine ligation beforehand and do the procedure. Maybe that it could be theoretically possible and reducing the blood loss, but it could be done with that. And therefore, this particular case was really a very, very challenging case to me. And of course, the patient has a very uneventful recovery and discharged after 5 days to the hospital. And subsequently, I kept the Follis catheter for about 14 days and removed the Follis catheter after that. So be very meticulous and steadily do the surgery at all levels. This is the uterine artery which I'm ligating it, but always with suture, not with this. So, and after that, you can find that the whole uterus can be delivered. And hysterectomy could be done. So these are the cases. The decision is important, and then your surgical planning and the removal is important for that. So must have done that. Yes, hysterectomy, cesarean hysterectomy is done. After the uterine, you find that yes, the bleeding is less and clarity could be there for that. Then this is the Mechanor's uterosacral ligament, which is being sutured, and then subsequently the vault has to be opened and the vault has to be closed for that. So these are some of the cases where the challenge to the hemorrhage, tackling hemorrhage in obstetric practice, and therefore I prefer that this episode will be dedicated to that arrest of tackling hemorrhage in that. So after now you see that yes, it is going mainly toward with one clamp, it will be over, the whole thing, uterus will be out, and you see that yes, it's at the end of the procedure, and after that the vault will be open and then things will be all right. Now, I will show after the benign surgery by benign gynecologist, I will just focus on the malignant gynecologist. And it's a courtesy video by the gynec oncologist of my friend Dr. S.K. Giri, my student, very promising surgeon, Dr. Mananjan Mahapatra from Regional Cancer Center. I told that yes, they volunteered themselves to give, because I was just supposed to tell this. They said that yes, I brought some courtesy videos, some alarming and very dashing videos presentation of tackling hemorrhage, pelvic hemorrhage, because the radical surgeons are more expert in that. And see, this is an external iliac vein injury repair. See, can you see that? The external iliac vein has got, they are not perturbed, and just arrest the bleeding, and then immediately this is a nodal dissection you can find, and they have sutured it, and it is being sutured, tackled at that. There is no need of calling the vascular surgeon, and this can be managed with that. This is a partial injury to the vein, external iliac vein. Can you see that with the 2-3 sutures, this absolutely is controlled with that. It's not a transection which is there for that. So this is one example. Now, this is a case where they have done the valval surgery, radical valvectomy, and there is a femoral artery blowout. Very rarely we find that inguinal ligament. They have done it on 12th post-op day. The inguinal incision where they have started there, where they have done the lymphadenectomy, and that suture gapped the dehiscence of that suture, and along with that, the femoral artery, there is a sudden blowout for that. So in that particular case, immediately with taking the help of the vascular surgeon, the femoral artery anastomosis could be done. Can you see that this is a femoral artery blowout, which is very rare, and femoral artery, there was a torrential bleeding, and this could be damaged. This could be managed immediately by the help of the vascular surgeon for that. So there is some cases where a gynecologist need to have a help from the vascular surgeon or the anastomosis if there is a total transection, because that is a very important thing. Believe me, the uterine artery versus the vein, the artery is easier than the vein. The veins are more difficult to manage than the artery for that. So this is one rare case for that. It's again a common iliac vein injury repair. Common iliac vein injury, there's a repair of that, there is an injury repair, and this video has been given by Mananjan to me, and see that yes, it is an unedited video, but it's a common iliac injury which is being tackled with that. So these are the cases where the radical surgeons, while dissection face more of that, the general gynecologist have a least chance of this very extensive injury to the major vessels for that. Now there is an injury. While dissection, can you see that there is an injury while with the mixture and they're dissecting the node and there is a, so these are the cases where don't be perturbed about it and how to tackle that. And this is the common iliac vein is there, but common iliac vein, if there is an injury also, they can repair like an external iliac vein, which you found out for that. Now this is again a case where the external iliac artery injury repair. Artery injury is much better. You can find that yes, the external injury, you can transection external iliac artery injury. These are all transection of the external iliac artery where the vascular pedicle has been used so that the bleeding is less. You can find the lumen and then anastomosis with that, with the fine sutures for that. And maybe that you can take help of the vascular surgeon. Now on the right side, you can find how the anastomosis is being done with that after transection of the external, because this is important. External iliac artery needs a anastomosis, otherwise they will lose the, particularly the leg. Amputation would have been much better. The gangrene will be there. So therefore, this is a very invaluable practice which all gynec oncologists are very conversant with that, and they should know about it. And even general gynecologists also should learn that. That's not a very difficult procedure, but try to prevent. Number one, go to the proper cleavage. Try to prevent. Don't take a credit of managing complications, but take a credit of preventing complications. That's my message which I will give it to them. This again external iliac vein and injury repair. While doing a, you can see the very good dissection out of it, and the finger is a better dissection for that. And last time I told how the finger is the best dissector ever possible. In my episode on dissection and decision, you can find that this is the external iliac vein, and the node is there, the nodal dissection is there, the psoas muscle is there. You can do a very good dissection with the use of the cautery, and at times you find that the external iliac vein is getting injured by that. And as in previous case, I showed how to make a repair. The repair of the vein is a little difficult than the artery, but the main problem arises in the internal iliac vein. Internal iliac vein, unlike the external iliac vein, the length is more, but internal iliac vein, the length is very short and it is deep into it. So there, internal iliac vein, you cannot catch it, and therefore you pack, press and pray will be the best principle of that. And if at all you can find it with the tissues, with the adjacent tissues, you put a figure of 8 suture, and that can be controlled with that. But the transection part, with the cannot be, anastomotic part cannot be done with the internal iliac vein, and that's a very important area where it is very difficult and a challenging situation for that. But therefore, unless you dissect it, they cannot do a lymphadenectomy, and therefore there is a risk of injury to the vessels, and tackling hemorrhage is very important for that. And I think this needs a lot of practice and procedure, but it's not a very difficult thing. Every gynecologist should also learn from the gynec oncologist how to do that, and by that the fear from the vessels, the fear from the ureter will be over if you practice the pelvic dissection for a radical surgery for that. So this is important. This external iliac vein and injury repair. We have already seen that, and the same thing happened here. And first of all, I will say that prevention is important, and if at all it is there, it is not very difficult. But internal iliac vein is a very important issue where it is to be given for that. So thank you, Sanjay, and thank you, Kedar, and thanks Allah for giving me this opportunity. I think we have crossed time more than half an hour. We have extended that, and thank you very much, my dear viewers, for spending few hours with me every fortnight. I'm very happy to have a audio talk with you. Even if I'm not seeing you personally, but it gives me and it cheers me for my teaching passion and compassion. Thank you.
Yes, sir. Yes, sir. Just want to add few sentences. There are so many messages, admiring messages, that they are giving hats off to your stamina without any sign of exhaustion. They are thanking you for your this stamina also.
Thank you, Sanjay. Can I request another thing? I was supposed to say this in previous episodes also, but couldn't make it. Today, I thought that seeing the number of viewers of mine and interested persons of mine, I will have one request to each one of you.
Yes, sir.
Every gynecologist here who are observing my this session of E-Gurukul for last 19 episodes, they are practicing day and night, and everybody must have experienced some clinical dilemmas and surgical dilemmas.
Yes, sir.
I wish, and it's a humble request to all of you individually that please forward any interesting case, any case where you find that there is a problem, you have faced it. And more important is the failure, not the success. Many people, they only highlight the success. I have done this and I have done that. I wanted some clinical dilemmas and surgical dilemmas on any aspects in gynecology, and request Sanjay, you give an email address of Juventus, and Juventus can help me because I am digitally very poor, physically very strong. So don't write to me. You always mail to the Juventus people, and you employ somebody, and somebody should be entrusted with that responsibility. All over the India, we find the clinical dilemmas and surgical dilemmas so that we can exchange ideas amongst all of us. And I will also learn from that. And then I will synthesize everything. You forward it to me. I will synthesize everything, and we can do special episodes on that also. We'll have a total interactive session on that, because we have almost covered many aspects for that. But surgeries, there is no limit. We can extend it continuously for that. But I want your participation. I think that is more important than my participation is. So it's a two-way learning for that, and everybody will share it because of your experience, because all of you are practicing day and night, and all of you must have seen various cases and problems. And even if you solved it, you just mail it. Even if you did not solve it, you mail it, and we can discuss it, whether you have done a right thing or a wrong thing, and how to improvise that. That's my honest request. I thought I will speak this. I was thinking every episode I forgot that. And today I thought that I will convey to Sanjay and Kedar, you be responsible for that, so that I'll be very happy. And my humble request to each one of you, even if it's a very small thing, don't hesitate. Even if it's a very small thing, don't hesitate. Even if it's a human error also, admit that. There is not a problem for that, because we, as a learning, we should grow. We should know what is the problem, and that is the basis of knowledge. Just reading books and theoretical and all that, I don't want. As a clinician, you are a surgeon or a clinician, it should be absolutely practical. Day in and day out, everybody must have experienced some of the different situations for that. Please share it.
Yes, sir. That's a great idea, sir.
Sir, with your permission, can we take question or?
Yeah, I'm ready.
So the first question is from Helen NG. She is from Imphal, and she want to know, how do we manage post-cesarean lower uterine segment bleed while doing cesarean?
How do you manage?
Post-cesarean lower uterine segment bleeding while doing the cesarean section.
Yeah, that's what I showed. That primary surgery is the best procedure for that. And lower uterine segment bleeding, you just, first of all, after cesarean, you demarcate the edges of the wound. And particularly with special reference to the two angles. Two sutures. I always say that don't put, many people hold with the Ellis forceps in the angle. I always say that two Ellis forceps on two sides of the angle, so that the apex will be visible, rather than putting one angle, so that at the end of the suture you will find a dog's ear thing on that. It's not a symmetric thing. And same thing on the middle part, on the lower uterine segment, you just hold it. And after delineating the edges, it is better and you can do much better suture and all that. Under vision, you can suture it for that. If it is not, say for example, a previous cesarean, bladder is adjacent for that. After that, you can again dissect it little bit, and so that you can find the two edges completely normal.
Kedar.
Yes, sir. The next question is from Dr. Mahitosh Mandal from Bongao. So he wants to ask, how should we approach to a bleeding patient?
Now, bleeding patient means there is a coagulation defect. Either if it is a coagulation defect, I think these are the cases, unless it's a emergency case, is a different issue. But elective case, you should have a pre-operative assessment, and that's why I've given emphasis on consultation with the transfusion specialist, consultation with the hematologist, and find out and rectify that. And if necessary, during the time of the surgery, you arrange that component therapy for appropriate use for that.
Yes.
And of course, commonly the ecosprin and clopidogrel used. Many cases we in gynecology, we use a lot of the aspirin, particularly in a case of recurrent pregnancy loss. Aspirin and low molecular weight heparin we use. And that's why this is preferable that at least 7 days prior to that, you stop that medications. Otherwise, the bleeding will be more.
Yes, sir. The next question is from Dr. Rahul Panigrahi. He is from Bhubaneswar, and he is asking, is external compression is the best emergency method to tackle PPH?
Now, this is a method where in the PPH also, the bimanual compression, I feel also I have experienced, I have tried that. Bimanual compression is also very good for that, external compression. And it's not that only compression with one hand. There are many people who compress the uterus along the spines, I think the vertebra. That's not good. But bimanual compression is actually, that's very good for atonic PPH for that, after delivery.
Yes, sir. The next question is from Dr. Nasreen. She's from Hyderabad, and she wants to know if there are big bleeders in LSCS at lower segments near incision line, then how should we proceed?
That's what I'm telling. Don't have a blind repair. If there are incision in the lower segment, before giving an incision, you just tie from below and above and made an incision in front, in between. So that is one. Suppose there is a bleeder in the lower uterine segment after giving an incision. You separately give a suture, and on the vessel bleeder, you control that bleeder and then start your suturing the wound closure. Don't combine it.
Yes, sir. Sir, the next question is from Shubhra Ketan Chakraborty from Kolkata, and question is surgical management of atonic PPH by conserving the uterus.
That's what I told. Surgical management of atonic PPH, if you want to conserve the uterus, the other methods like stepwise devascularization, the suction in stop, or the compression suture, all these are for atonic PPH, or the tamponade, all these are for the atonic PPH.
Yes, sir. So the next question is from Purnima Nepram. She's from Imphal, and she wants to know, in severe anemia, in how many days gap can we repeat iron infusion of ferric carboxy maltose?
Purnima is always very sincere. From the first episode you are there.
Yes.
I know that you are so sincere. In severe anemia, if it is less than 4.5 gram %, there is a place for blood transfusion. There is no disagreement for that. And blood transfusion is not given to raise the hemoglobin from 4 gram % to 11 gram %. You just make it 1 or 2 units of blood to make it a moderate anemia, and then you can give the iron, ferric carboxy maltose, you can give it. There is not a problem. But in a case where at least more than 6 gram % without any symptoms, you can start ferric carboxy maltose also without blood. But in severe anemia, blood transfusion 1 or 2 units to avoid the crisis, and then you can use the give the ferric carboxy maltose. That's not a problem.
Yes, sir. Sir, the next question is from Dr. Priti Prasad. She is from East Champaran, and she is asking, does viral infection in pregnancy cause coagulation disorders?
Well, viral infection pregnancy, and now everything is viral infection means you think of corona first. I think there is a lot of studies now. effect of corona in pregnancy. By this time, there is a lot of studies which have done. The two most acceptable things which you find that a preterm birth. Preterm birth is more often found, and incidence of cesarean section is more often found because of the fetal conditions, because of the saturation, oxygen saturation, and all that dropping. So apart from that, the vertical transmission is yet to be evaluated, and the bleeding is yet to be evaluated for that also. And I have few experiences also. The D-dimer, you estimate the D-dimer, and post-COVID, many cases, COVID, frank COVID, I don't have any experience, but post-COVID, I have experienced that the D-dimer at times persists for a longer time. And I was a little skeptical in D-dimer, but I didn't find any difference. And bleeding is not more in that particular case for that. Just 4 days back, I did one cesarean where the post-COVID, but post-COVID is about 20 days, 30 days before, 1 month before. But the baby, I delivered the baby. It was a clear liquor, 2.8 kg baby. But there was a problem in resuscitation. The baby didn't cry. And it took the bag and mask for 2 minutes. After 2 minutes, the baby cried, and then subsequently it doesn't need any NICU therapy, NICU. So I hope that this could be some link, and more studies is warranted on this viral infection.
Yes, sir. So Dr. Purnima has another question for you. She wants to ask how to manage a case of bleeding PV following post-hysterectomy.
That's why I told post-hysterectomy bleeding, commonly the bleeding occurs in spots, small bleeding PV. Small amount of bleeding PV for a few days, it continues, and it doesn't cause any problem. And that is usually resolving by the systemic tranexamic acid or just conservative management of antibiotics and all that. But massive bleeding, if it is a active bleeding massive, you must inspect what is that, whether it's bleeding from the vault, whether it's an active bleeder from the vault. You have to repair it, put a stitch on that. But remember, the hysterectomy, post-hysterectomy bleeding, try to avoid the pack. Normally, I don't want to give a pack on post-hysterectomy bleeding, because pack is given when the whole thing is absolutely in a cavity. But here, the upper part is gapping. So if you give a tight pack also, there is chance that the vault will be open by the pack itself. So you inspect it. They inspect it and find out the source of bleeding and repair it either vaginally or abdominally.
Yes, sir. Dr. Pratibha Gupta and Dr. Prerna, they have a question regarding the case number 5. Dr. Pratibha is from Vadodara and Dr. Prerna is from Firozabad. And the question is, sir, was there a blood in peritoneal cavity?
No.
Regarding the case number 5.
No, there is not a blood in the peritoneal cavity.
And the question from Dr. Prerna is this an extra peritonization?
Extra?
Peritonization.
I forgot. Which case, the post-hysterectomy bleeding, no? Carcinoma endometrium.
Case number 5.
I forgot that.
Okay, sir.
I think in the carcinoma endometrium, there was a bleeding, and on the right angle of the vault, there is a vascular mass. On dissection of the vascular mass, I did a laparotomy and sutured it with that.
Okay, sir. Thank you.
Okay, sir.
Thank you.
Dr. Preeti Niranjan from Vadodara wants to know your opinion about not separating bladder peritoneum in LSCS.
Not separating bladder peritoneum.
Bladder peritoneum in LSCS.
No, bladder peritoneum, I always open. I don't do it mainly give an incision without opening the bladder peritoneum for that. But in a previous cesarean, Preeti, always again, same principle arises from lateral to medial, not from medial to lateral. Because medial, there is a chance that in a previous cesarean, there will be adhesions for that. And you have to open it. And many cases, if there is a difficulty in separating the bladder, at least partly separate it, deliver the baby, and after deliver the baby, then hold it the lower uterine segment, the wound, and then it is much easier to again go a little below that. But you have to separate it.
Yes, sir. Dr. Rita Malik from Delhi and Dr. Aradhna from the Noida, they are admiring and they are saying that great teacher, great stamina, hats off to you, sir. Thank you, sir.
Thank you.
And
Thank you. I do
listen to
reciprocate.
your experience for hours together.
Thank you.
Yes, sir. Dr. Aradhana from Noida has posted a question, sir. I'll just read it to you. She is asking, what is the treatment for diffuse adenomycosis of uterus with huge 20 weeks uterus in young unmarried 34-year-old female? Already one attempt of large adenomyectomy done and it's again recurred. Patient wants hysterectomy to avoid repeated surgeries.
I think it's wise. If the patient wants, she's 34 years and she has already attempted for IVF and she has already done an adenomyectomy and the uterus is 20 weeks. I think I think these are the sufficient reason for doing a hysterectomy. The quality of the life will be much better and you accept that the patient wants hysterectomy, you do the hysterectomy. I think it's much better, but the technique of hysterectomy is little difficult will be there because there is a previous history of adenomyectomy. You expect a lot of adhesions and very carefully you do it, preservation of the rectosigmoid and the ureter and all that. And it depends whether you can do a laparoscopic approach or you can do a laparotomy as per your wish for that. There is not a problem for that. Even some people do a laparotomy. I will welcome that. In that particular case, laparotomy is also much safer than the laparoscopic approach. You do it.
Yes, sir.
Yes, sir. There are so many messages, greeting messages, but because of time, sir, can I read or we'll
Thank
stop
you.
here?
Thank you very much. Convey my best wishes and I do reciprocate to all of them. But
Yes,
note it down. I want your feedback directly, and one of you take charge. Sanjay, you can give charge to somebody who will receive all the emails and send it to me so that I will scrutinize. It will be a very good e-book, complications and all dilemmas book. We'll make it a Juventus dilemmas book with the Juventus. There is not a problem.
Yes, sir. Yes.
Thank you.
Thank you very much, sir.
Thank you. We'll leave. Again,
Yes,
we are
sir.
meeting after 2 weeks. Or is the end? Alad?
Yes, sir. Sure.
We'll continue the episode or
We'll
stop it?
continue, sir.
We'll continue the episode.
Yes, yes,
All
sure,
right,
sure, sir.
all
Sure,
right.
sure.
And I have told, I think you must have listened. I've told this idea
Yes,
came
yes.
to me
Right,
that I appeal to all my viewers, give their feedbacks and their own experiences on that particular things, so that we can do a lot of things.
Yeah, that's an excellent idea, sir. That's an excellent idea. So that there is more of interaction which happens.
Yeah. But believe me, I can act through you. You are my strength. So they will hand over to you, and then you will write to me, and then we'll do that, so that it will be perfect.
You're always welcome. So we'll work.
Thank
it.
you.
We'll work it.
Thank you,
Sure.
Alad. Good
Thank
night.
you, sir.
Thank you,
Thank
sir.
you. Good night, sir.
Thank you so much for
Good
wonderful
night.
presentation.
Good
Sir.
night, Kedar, Sanjay.
Yes, sir. Good night.
Sir.
And convey my best wishes to Devan.
Yes, sir.
Thank you.
Sure.
Yes.
Sure. Yeah.
Thank
Thank you.
you.
Thank you.